You are live now, ma'am.
Thank you. Good morning, everybody. It's a very pleasant Sunday morning in Bangalore. And we are very excited because today we are having the state competitive resident virtual session. And we have 11 eager postgraduate ophthalmology students who are going to present some unique cases. And they're going to compete with each other to get that first prize. So all the very best to you. If you have heard about Marianne Williamson, Marianne Williamson said that your deepest fear is not that you are inadequate. Your deepest fear is that you can shine beyond measure. Today, I want each one of you to shine beyond measure. And remember that we have Dr. Mohita Sharma with us, the champion of the Women Ophthalmologist Society, the Secretary All India, WOS. We welcome her wholeheartedly to the beautiful state of Karnataka. Welcome, Dr. Mohita Sharma. We have Dr. Shilpa Kodkarni with us. And if you are ever in the area of Belgaum or in nearby Belgaum also, you should make it a point to visit Kodkarni Eye Hospital. It's definitely a place worthwhile to visit and worthwhile your time. She's a proficient phacoemulsification cataract surgeon and a refractive and a cornea specialist also. She is going to be the moderator for our entire session today. And I hand over the session to Dr. Shilpa. Over to you, Dr. Shilpa Kodkarni.
Thank you, Dr. Samina. And I'm sure it's going to be a wonderful session this morning on a Sunday morning. I welcome Dr. Mohita Sharma. She's been the inspiration for all women ophthalmologists in India. Without her, we would probably not have had a Women Ophthalmologist Society. So I welcome Dr. Mohita Sharma. And just to give a brief introduction, everybody knows her, but for the proceedings to start, she is founder and chairman of Tirupati Eye Center at Noida. She specialized in cataract and refractive surgery as well as retina for the past 27 years. She is General Secretary, UP State Ophthalmological Society, Women Ophthalmologist Society of India, Women Ophthalmologists Worldwide Network. She's ex-secretary IMA Noida and ex-president and secretary of Noida Ophthalmological Society. She has been an invited speaker for more than 400 national and international conferences. And that's not all. She has won many awards. Just to name a few, the WIO Honorary Award 2017 at San Diego, USA, Champions of Change Award, WOC 2018 at Spain, and the President Appreciation Award, IMA 2017 and 18. So without much ado, I invite Dr. Mohita Sharma to give her keynote address for this proceeding.
Thank you so much. Thank you so much, Shilpa. And good morning, everybody. And very, very happy to be a part of this session and to see this happening. Thank you, Samina, for doing this. And thank you, Shilpa, for being the biggest support always. In fact, I remember that first meeting of WOS, which we had, that was a breakfast meeting at Karnataka, at Bangalore, again with Samina and Shilpa being there. So now we've come down from there. We've come down, I think it's around 6 to 7 years. And that was, I think, an example which was set by you all. And since then, there have been events happening everywhere. And so much is happening in WOS, all just because of you. Because taking that first step is the most challenging thing. And you did that. And you set an example for so many others. So, first of all, I would like to welcome all the new members who have joined. I can see that many of you young ones have joined as members, and I'm sure many of you are about to join. So I will give you a brief overview of what WAS is, because this would be your probably the first experience with WAS, and now that you are a member or you would become a member, you would have several such experiences, and I'm sure we are going to love those experiences. And before when I start talking about WAS, thank you all the mentors, because you are the ones who are responsible for today's program, as well as you are the ones who are responsible for what WAS is working on. So WAS is basically a society which is working. Most of its programs are based on mentor-mentee concepts, and the whole idea is to give more opportunities to women ophthalmologists, and mentors and role models help them grow up to their full potential. So I can share my screen. So today we are around 2,500 members, and we are 18 state chapters, and we are growing very fast. But everything here is voluntary. We have never gone on something called, as societies do, a massive membership drive. We always feel that whoever feels that they need to be a part of WAS will join WAS, and they have been joining. The whole concept of WAS is givers gain, which means the more you give, the more you get. So here nobody thinks about what they can actually extract out of other members. Everybody thinks about what they can give to the other members. And when you start doing that, then there are so many others who start thinking what they can give to you, and that is the whole concept which we are working on, and which has been very successful in WAS. So everything is to do about mentoring and about mentor-mentee program. And the surprising thing is, not so surprising to us, but to a few mentors, which they share also, that once they got into the mentoring role, they realized how much joy is there in giving, and they actually started feeling good about it. And that's how there is a big pool of mentors who are a part of WAS. So WAS is all about being different. The kind of programs that are designed are meant specially for women ophthalmologists, and there are some programs which are initiated by WAS, but they are both for men as well as women ophthalmologists. So there are around 20 to 25 activities that happen all over India, and sharing the first photograph, which I talked about, photographs of the first breakfast meeting, which Samina had conducted so well. And I think Shilpa was also there, Madhuri was there, and several others. I'm sure you can see and remember. And we feel so proud that now we have reached where we have reached after this first meeting. So we have had 4 annual conferences, and these annual conferences are basically a little different from any other society conference. For example, we started with live surgery sessions by only women surgeons, because we found that women surgeons were not operating live, and then we graduated to mentored live surgery sessions where junior women ophthalmologists operate, and the seniors are in the mentoring role with them in the operation theater. And it's a pleasure to see how well they do, and how confident they become once they have done this, because they could at that young age, they could never imagine that they would be doing live, and once they have done live, all their fears go off. And so this is what we encourage in WAS. And these are just some photographs of sessions. It's a very happy atmosphere. It's a very a progressive atmosphere, and it is a very pulling up atmosphere. So these are some of the highlights.
पाउंड है और यूरोप का यूरो है। 2016 के अंदर
Mr. Singh, kindly mute yourself.
स्थान दिया गया।
Everybody to please mute
अर्थात
yourself.
इस बैंक में 5 मुद्राएं शामिल की गई। अब आप पूछेंगे कि सर इस बैंक में हम भी
Mr. Bhageshwar. Okay, thank you. So we have just a few highlights. We have leadership sessions, research sessions, sessions on medical legal aspects, sessions related to women's health. We have innovation sessions, state competitive sessions, etc., etc. A lot of sessions which are different from other conferences, and we have. So basically this started a few years back when we thought that we want to tell you that you're not alone in your professional journey. And this was the first mentoring program that was started, where there were these 25 mentors who were mentoring one to three women ophthalmologists as mentors. And then we have these one-on-one sessions also, where you can choose a mentor and you can have a virtual session for 1 hour with a mentor, and later on it becomes a connection for the whole year and sometimes for the whole life. We have these rendezvous series where you will find successful women and men ophthalmologists sharing how they reached where they reached, and you can be interactive with them also. And we have these leadership sessions also, where leaders share how they became leaders. We have inspiration series, we have international award-winning presentation series, and we have life beyond ophthalmology also, which is also important. And for now, in this current year, we have these two competitive sessions going on already. Already there have been, I think this is the eighth state participating, and all the best to all the young ones who are participating today. Do your best, and as was said earlier, it's not important to win or lose, but it is important to give in your best. And once you have performed on this, presented and performed on this forum, you will find your confidence goes up tenfold, and you come into that mode and also see how others are performing and how you can improve. And in fact, you should go back and see how, if there was from the winners, what was the difference between your presentation and the presentation of the others, and thank your mentors who mentored you for this. So WAS is another project called Project Archana, which has been started, and this is after one doctor called Dr. Archana from Rajasthan committed suicide after a death of a patient. So there are new challenges as doctors which we are facing in the form of dissatisfied patients, angry patients, violent patients, and even moms sometimes. So Project Archana is working on this, in which we are teaching you how to keep your cool physically, mentally, and legally protect yourself. All these things are important too, because they are not taught to us in our curriculum. We are making an emergency helpline for any challenge that you may have related to patients, and we are encouraging all states to go and meet the police, so that because you should once you are friendly with the police, you can teach them what actually the law is, and so that accordingly they can behave. I just put a picture of myself with a police commissioner of my area, because I just wanted to highlight that once we become known with the police, our fear for the police or the press trying to hound us goes away, because we realize that they are actually friendly people and they listen to what you want to tell them if you're right. So we have award sessions where we felicitate those women ophthalmologists who are doing well, or sometimes even those who are doing well but not very known in this thing, because not all women project themselves even after doing good work. And this is also one aspect that we focus on. We tell you how to project your work, because that's important too in today's world. Then we have this Women in Research Network, because this was started around 5 years back, because we felt that there's an untapped pool of large women ophthalmologists and only a handful of institutes that are in research. And women are by nature creative and persevering. So this is a network in which we are trying to encourage women, whether they are in institutes or as solo practitioners, to get involved in research. And this 3 photographs I'm sharing of 3 women ophthalmologists who, with the Women in Research projects, they have got 3 projects this year from Department of Science and Technology, Government of India, and they are already started on these projects. So just these are photographs of how our research sessions have been happening, and we have a ethics committee of our own. So if you do not have an ethics committee, you can use the ethics committee of WAS if you're a WAS member. And some of the early Shilpa is also there. So some of the early researchers, and there have been several such sessions, several studies started, and several such teaching sessions, training sessions, etc. So I here on this slide, this is a very important slide because in July we are launching the webinar website, and here you will find a lot of national and international opportunities for research. You know, there are so many research opportunities. Like I shared the photographs of the 3 ladies who got the Government of India project. There are so many such opportunities which we do not even know of because we think that they are not for us. So this website is sharing all those opportunities, and it is not this you just have to be a researcher. You could be doing your clinical work and add on a research project along with that. And so this website will give you all those opportunities. And this has to be wasindia.org. You can go there, and then we'll announce, if you're a member, you'll get all the information about when we announce this website. Website is ready. It will be live in a week's time, where the final launch will happen in July, but in a week's time only. As soon as it is live, you can actually look into those opportunities. We also have research mentors there who can actually mentor you for those research projects also. So just giving some pictures of the national and international opportunities which are there, which are waiting for you, and you have to take them, and WAS will be instrumental in doing this for you. And about the RED group, which is our rare eye disease project, again, we have started with 10 rare eye diseases, and the leads have also been almost finalized. And each rare eye disease would have around 60 to 70 investigators. So if you're interested in that, you can become an investigator, and we will help you get into research. Or if you're already into research, it will be a great help for us if you join that research group. And finally, what we want to say with this webinar is that research is possible, research is for all, and even with your clinical work, you have to be involved in research, and that is when you will find that you would be very happy doing your work. And last but not the least, we found that there was, similar to WAS, there were societies existing across the world also. We found these 4 societies of women ophthalmologists, and then that's when we formed this Women Ophthalmologists Worldwide Network. And this was formed in 2020. This has now 29 countries in it. And we are proud to say that because of this WOW network, from 4, the number has jumped to 7, which means 3 new women ophthalmologists organizations have been formed across the world, and more are into formation. Now, the advantage for you is that once you become a member of WOW, you get connected to women ophthalmologists all over the world, and you have so many opportunities for networking, for collaborations, for fellowships, for observerships, etc. All you have to do is to go to this website, which I've written here, wowophthalmology.org, and for this year, the membership is complimentary. So go and fill up your name today and become a member of WOW too. Finally, mothers saying, I alone cannot change the world, but I can cast a stone across the waters to create many ripples. And this is what many of our pillars of WAS are doing, including Samina and Shilpa, and we are very, very proud of them. And there are many other names which I'm sure are doing good work, but I'm not able to take their names, but they all deserve a big applause. Thank you very much, and welcome once again to WAS.
Sincere gratitude to Dr. Mohita Sharma that she spared her Sunday morning time with us. I hope that you can stay with us for some more time, Dr. Mohita. Whenever I hear Dr. Mohita speaking, I remember Sheryl Sandberg, that she once said that, what would you do if you were not afraid? You know, so many times we are afraid of getting embarrassed, afraid of what others will think. But there's one thing which I have learned from Dr. Mohita is that do not be afraid. And friends, young students who are going to present, please remember that. If there are any questions you want to ask for some other presenters' case also, please do not be afraid. We are here today and you will be listened, and you will get answers. So thank you once again. I take this opportunity to welcome the judges for the competitive session. Dr. Suma Krishnan, a retina specialist at Zaminda's Microsurgical Eye Center. Dr. Rita Gangwani, retina specialist at Ahmedabad Eye and Laser Center. I'm not sure whether I see Dr. Divya, but welcome to her. Dr. Shilpa and Dr. Samia Bassan are speakers, and they are also judges for the cornea section of the competitive session. So welcome again, Dr. Samia Bassan, a cornea specialist, and Dr. Shilpa. Now we are all very keen to listen to Dr. Shilpa. Dr. Shilpa is going to talk to us about the diagnosis of a corneal ulcer. And I'm very excited to listen to that. Dr. Shilpa, over to you. Please share your screen.
Yeah, thank you, Samina, for the wonderful introduction. Well, I thought I would talk today on diagnosis of a corneal ulcer, especially because we have our young postgraduates and fellows with us. Very, very basic things which are very important. And I see in my practice that especially in 2-tier and 3-tier cities, corneal ulcers are a major part of our practice. And it's very important to diagnose them rightly so that we are able to give them the best possible treatment. And it is very possible to give good vision in patients with corneal ulcers, which otherwise in the past were told that there is no remedy and they are blind forever. So just a few very basic things that I would like to touch upon is, first of all, the incidence of corneal ulcers in India. It is seen that 60% are fungal keratitis, the rest being bacterial 20 and viral being about 17%. And in the rural populations, the incidence is much higher as compared to the urban population. Now, it is seen that even in the rural population, or any population for that matter, it is the farmers. Because of the occupational hazard, they are in touch with more of plants, trees and everything. And these kind of injuries, vegetative matter causing fungal ulcers, is quite common in them. Now, epidemiologically, approximately 2 million people develop a corneal ulcer every year in India alone, and almost 50%, like I showed earlier, are fungal keratitis. Now, having said that, fungal keratitis being so common, most commonly is due to vegetable matter. And in the urban population also, nowadays, we see a growing or an increasing incidence because of contact lens wear, as well as ocular surface diseases. Now, the fungal pathogens, most commonly we see Aspergillus, Fusarium, Candida. These are the most common, Aspergillus being even more so. Now, when we see a patient with a corneal ulcer, there are certain signs that tell us that this could be bacterial, this could be fungal, this could be viral, but the investigation is very, very important. And they are very, very simple investigations. Just a simple gram stain and a KOH will help. Of course, viral keratitis is on signs itself you can make out, but sometimes what we have seen is bacterial and fungal can be very confusing. And simple test, that is the KOH preparation, that is 10%, and the gram stain. Of course, culture and sensitivity are going to give more of specificity to your diagnosis, but these stains will give you a diagnosis in 10 to 15 minutes, and you are able to start the right treatment for your patient. Now, KOH stain, we can see hyphae, we can see spores, by which you can more or less come to a diagnosis, whether it is Aspergillus, Fusarium, or if you see spores, then it would be Candida. Calcofluor white, on fluorescent microscopy, you can see such hyphae and also sometimes spores. There can be a mixed infection also. Now, the laboratory diagnosis, which has been a conventional method, but it is even today very, very specific. And it is seen that KOH staining, especially for fungal corneal ulcers, it is by and large almost 90% specific. 90% of our fungal ulcers can be diagnosed by a simple KOH staining. And I would suggest not only to, since we have our postgraduates here and fellows, do the slides yourself. Look into the microscope yourself. It is very, very useful. Instead of
Dr.
just...
Shilpa, sorry to interrupt, but
Yeah.
Are you changing slides? Because we are seeing your first slide only.
Yeah, I am.
No, we are not seeing that. We're just seeing your first slide.
Okay, 1 second. Can you see it now?
Yes, yes. Maybe you would like to just quickly show us the previous slides, you know? Yeah.
Are you able to see them?
Yes, we can see laboratory diagnosis. Yeah. Everyone, please take notice of this, that, you know, you have to put it on slideshow or play so that the slides move when you move. We can see laboratory diagnosis, yes.
Yeah, but it's not going further now.
Okay. You can take your time and go back to the main, the first one. Sorry that, no worries, we'll wait. Yes, we can see the first slide now, diagnosis of corneal ulcers. Can you just move to the next slide now? Yeah.
Able to see this now?
Yes, yes, we can see the slide. It's not on the play mode, but we can see the slide. This is also all right. If you can go to the next slide now.
Now, can you see laboratory diagnosis?
No, no. We are just seeing diagnosis of corneal ulcers. There is a slideshow. Would you like to go? Yes, now we can see laboratory diagnosis. Yeah, yeah, we are good. We're good now.
Okay.
Yep. Yes.
Now you see?
Yes, yes, very much.
Okay. There are other methods also, the newer methods of diagnosis, which are PCRs, but they would take about 4 to 8 hours, and also in vivo confocal microscopy, which is able to give you a better diagnosis of what exactly that organism can be. There are some better methods, like, of course, scraping and debridement. It will also help not only for diagnostic, but also from the point of view of treatment, and also for better penetration of the drugs. If the scraping that you have taken shows that there is no organism, it's negative, then you can also do a small corneal biopsy. And in cases where you have a deeper keratitis, you can use either a 26 or 27 gauge needle, or maybe a 6-0 silk suture, which can penetrate deep into that infiltrate, which is deeper, and take the specimen from there. And of course, if you have a hypopion, you can also, or an endothelial plaque, you can aspirate it from the anterior chamber and send it to the laboratory. And in very bad cases, when you need to do a therapeutic keratoplasty, you can even send it for a HPR. Now, signs are very, very important. In fact, they clinch the diagnosis much better than any other diagnostic modality. In fungal corneal ulcers, we find that the signs are more obvious than the symptoms. The patient may not complain so much, but the signs are very, very vibrant. and it is a slow progression. So if you compare the signs of bacterial, fungal, and viral,
Doctor, please change the slide. Yeah.
I have changed the slide.
Yeah, we are seeing only laboratory diagnosis.
I don't know why that's happening. Okay, can I just do?
Yes, we can see the signs now.
Yeah.
We can see it
So
now.
I will not go into the slideshow mode. Okay. Can you see this here?
Yeah, we can see signs now. Yes.
Yeah. So the epithelial defect is more prominent in a bacterial ulcer with a large infiltrate, and there is a lot of ciliary congestion. Whereas in a fungal corneal ulcer, if you can see here, it is a grayish infiltrate. It is slightly more stromal. You normally don't see any epithelial defect. Are you able to see the slide which has changed?
Yes, we can see the fungal corneal ulcer. Thank you, doctor.
Yeah. And the margins are very, very fuzzy or blurry. Whereas in a bacterial ulcer, the margins are quite well defined. You see satellite lesions. As you can see here, these are the satellite lesions that you see towards the periphery. And of course, the hypopion, which is a thick hypopion. And you can also see a corneal abscess like this. Now, this can confuse you with a bacterial ulcer, but as you can see here, you can see those satellite lesions as well as you can see fuzzy margins. That kind of tells you that this is fungal and not bacterial. The hypopion, as you can see here, very diagnostic of a fungal ulcer and feathery raised kind of an ulcer that you can see. And this is when it goes really bad, when there is no other option but to do a therapeutic PK here. Now, bacterial ulcers, like I told you earlier, it is the epithelial defect is quite significant that you see, and the margins are quite well defined. This clinches the diagnosis of a bacterial ulcer. Now, in bacterial ulcers, usually it is the Staphylococcus, most often the Staphylococcus pneumoniae and Staphylococcus aureus, which are most commonly seen. This is another case of a bacterial ulcer, which is quite large. The infiltrates have progressed, but still you can see the margin being quite well defined. Now, viral keratitis, most often it is herpes simplex or zoster. You can see sometimes punctate lesions like this, which are subepithelial, or you can see these kind of dendrites or geographical kind of ulcers. These are, of course, very, very diagnostic. And another thing, especially in herpes zoster infections, we see patients who come to us much before the formation of vesicles, which are very diagnostic. At that time, you don't even look into the eye probably. You just look at the skin or the eyelids and you know it is herpes. But very often the patient presents with just congestion. There's nothing on the cornea. It's only a congestion that the patient presents with. But the lid edema and the congestion do not correlate. There is more of a lid edema which is seen, which kind of tells you, yes, this is a viral thing. And if you don't diagnose it at that time, the patient will come to you 2-3 days later with those classical vesicles. And then you say, oh yes, this was herpes. So this is how very often patients present with, we think it's just a simple viral conjunctivitis, but then they present with a herpes zoster infection. Very, very commonly seen like this in the initial stages. So just to summarize, it's very important that the history taking is of utmost importance, that when you see that a vegetative matter is the cause for the injury, then you kind of know this could be a fungal. Of course, symptoms are very, very important because, like I said earlier, in a viral zoster infection, they present only with congestion first, with just more lid edema than the congestion. So symptoms also help you, signs help you, like I showed earlier, the different ways of presentation of fungal, bacterial, and viral, and the investigation, the simple method of doing gram staining and KOH. So viral, any kind of corneal ulcer is not very difficult to treat, provided you do a proper diagnosis. And to diagnose, simple investigation, just looking a little bit keenly and closely at the signs will clinch the diagnosis. Thank you so much for a patient hearing. I hope I've done justice to the topic. It's very vast, but I thought just these simple tips should help. Thank you so much.
Thank you so much, Dr. Shilpa Kodkani. It was really a wonderful talk today, and it was a good revision for all of us for the diagnosis of corneal ulcer. I'm sure everybody has benefited from your talk. Sincere gratitude. I think over to you again, because you will be now introducing our next speaker, Dr. Samia Bassan. So go on, Dr. Shilpa.
Yeah.
Thank you so much again.
Thank you, Samina, for this opportunity. And I hope it has benefited our postgraduates and fellows especially. Now we go on to our next speaker, Dr. Samia Bassan. She is a cornea consultant at Zamindar's Eye Center since the past 5 years. She completed her secondary DNB from Solanki Eye Hospital, Bangalore. She's done her fellowship in cornea and external eye diseases from Retina Institute of Ophthalmology, Minto Hospital. Keen interest in keratoplasties, keratoconus, and contact lenses. Over to you, Dr. Samia, for your presentation.
Thank you, Dr. Shilpa, for the introduction. Is my screen visible? Yeah. Is my screen visible?
Yes, Dr. Samia, your screen is visible.
All right. A warm welcome to everybody. It's nice spending the Sunday morning with the stalwarts of WOS on one spectrum. On the other end, we have the young, enthusiastic PGs and residents, from fungal corneal ulcers to dry eye. Though dry eye is a simple clinical entity, often we miss as residents, if you inculcate this habit of recognizing, of course, if it's severe dry eyes, I think everybody will, make a note of it. But yeah, if we recognize the early signs, mild and moderate symptoms of dry eyes, I think, the patient will be benefited in the large. Today, I'll be talking about a structured clinical approach, more dealing with the evaluation of dry eye rather than the treatment aspect of it. Why there's an increase in prevalence of dry eye? There have been a lot of studies
Dr.
worldwide.
Samia, sorry, but we are not seeing the second slide. I think you would like to change the slide now.
Yeah, I think I'm having the same problem or issue as Dr. Shilpa is having, probably because of the virtual background, I think, because I am changing and somehow it's not visible. Now I'll just keep it in this mode itself, ma'am.
Yeah,
I think so. I'll just keep it in this mode itself.
Yeah.
So that, yeah, if I go into that, this thing, the other mode, I don't think the others can see. Okay. There have been a lot of studies. Shall I continue?
Yes, go ahead.
Yeah, there have been a lot of studies across the world where it was population-based studies where they have taken a look at the prevalence of dry eyes. There is a Blue Mountain Eye study and a Beaver Dam study from various continents. We have even the Indian studies with Samia Bassan et al. Who have looked into it. The prevalence almost, covering about 5 to 50% in the population. The population included also have been anywhere between 20 to almost 50 years. So there's a high prevalence of dry eyes existing among our patients. Why do you think there's an increase in the dry eye prevalence? There's a change in our lifestyles, use of air conditioners, more and more computer usage, and Bangalore being an IT capital, I think we have more number of dry eye cases in Bangalore, increased awareness, and people do seek medical attention, surgery, post-refractive surgeries, preservatives because of usage of a lot of drugs, anti-glaucoma medications, antihistamines for allergic conjunctivitis, increased life expectancy, and change in the definition what the TOFS has given us. Here I would like to quote the TOFS dues to definition in toto. They initially came up in 2007 with a definition, and which was modified recently in 2017. It's a multifactorial disease of the ocular surface characterized by the loss of homeostasis of the tear film and accompanied by ocular symptoms in which there is tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities which play important etiological roles. This is the change definition, which has encompassed a lot of things which they have taken into consideration. Next, I'll be going how to classify it. Initially, what the classification given by TOFS or DUCE was, I mean, there was a broad classification as aqueous deficient or evaporative dry eye. But now if you come to the bottom half of the slide, they are not mutually exclusive of each other. There's a lot of overlap between the two. We don't see them as separate entities. Most of the patients can have both of them. The upper part of the slide shows a clinical algorithm, the way we classify when patients are asymptomatic, symptomatic, and when they exhibit signs, and when they don't exhibit signs, how to go about it. Patients who are symptomatic and exhibit signs, if you come to the center, if my cursor, if you can see, that is when we use triaging questions so that we can classify them and classify dry eyes and therefore treat them. There's a separate entity if you come to the FAG and right corner where the patients are symptomatic but no elicitable signs. This is classified as a separate entity called as a neurological or a neuropathic pain, where they refer to a plain clinic. This, I think most of us come across this, and if it is missed, we might be just treating them with tear substitutes forever and ever. And how do the patients present to us? They have a varied symptoms. They can present with ocular irritation, tearing, burning, stinging sensation, dry eye, foreign body, or a sand or a gravel feeling inside the eye, photophobia, blurred vision, mucus or a thready or a ropey discharge, eye fatigue, strain. There are a variety of symptoms that they can present to us with. How do we go about a diagnostic approach when you see a patient like this? Of course, they can have other ocular surface disorders also. How do we know that this patient is a case of a dry eye? Whenever you train your optometrist as residents, you can yourself, when you do the vision, when you take the history, when they come or present you with such complaints, you can use a questionnaire and use these triaging questions. When you get a positive number on those triaging questions, then further subclassify and do some diagnostic ancillary tests. That's when you can classify them either as evaporative dry eyes with MGD, or an evaporative dry eye, an aqueous deficient dry eye, and further, which will help us treat them. We have come across, there are so many dry eye questionnaires that you come across. You have the OSDI, Speed, McMoney's, Salisbury, multiple number of available options, but the most commonly used one is the Ocular Surface Disease Index scoring system. It's used worldwide. Here, this is a scoring this thing, OSDI format, which I've shown it. It's available on the net. You can download it and please hand it over to your patients. I'll tell you which category of patients you will have to give this to. There are a subtype of 3 subclassifications with 12 questions. There's a scoring pattern between 0 to 4, and you summate all this. Then you go to the back of the brochure. You'll have how to calculate the OSDI score. This OSDI score is the total number of questions answered into the number of score when you've summated all that, divided by the number of questions they've answered. You get a scoring pattern anywhere between 0 to 100. 0 to 12 is taken as normal. Anywhere between 12 to 23 is taken as mild dry eye. 23 to 33 is taken as moderate. Anywhere above a score of OSDI score of 33 is taken as severe dry eye. Who are these OSDI questionnaire recipients? When whoever present to you don't give it to every patient that come to your, whoever walks into your OPD. All these diabetics, pre and perimenopausal women who are on hormone replacement therapy, computer users, all kinds of allergic disorders. Bangalore being an allergy capital, we see a lot of VKCs, contact lens wearers. It could be soft contact lens or RGP lenses, secondary to any ocular or chemical burns, post-refractive surgery patients, patients on certain systemic drugs and topical drugs, where I've enumerated. Systemic drugs like antihistamines, anti-rheumatoid agents, antiarrhythmics. Topical drugs encompass most of the anti-glaucoma medications and antihistamines, especially your olopatadines. Please make a note of all this. After we have noted all this, how do we go about examining these patients? We do both a careful external examination as well as a slit lamp examination. External examination could be as soon as the patient walks into your OPD, look at the gait of the patient. Probably if they have any kind of rheumatoid arthritis, their gait could be altered. And coming to the external eye per se, take a look at the margins, anterior and posterior lid margins. Take a look at the blink rate, look for any lag ophthalmos in case of seventh nerve palsies, any ectropions, entropions, and thyroid irises where there's proptosis, or in cases of myopia where there can be pseudoproptosis. Take a look at the skin, look for any scleroderma, thickening of the skin, especially of the fingers, any facial changes, rhinophyma in cases of acne rosacea, any chemical traumas, mechanical or thermal burns, or post that there is scarring of the eyelids, any joint deformities which are characteristics of rheumatoid arthritis. Look for any Raynaud's phenomena, splinter hemorrhages, which are characteristically seen in cases of scleroderma. Coming next to after we have taken a look at the patient thoroughly, under diffuse examination, look at the lids, blink rate and everything. A slit lamp examination where we look for the tear film, observe the tear film carefully, look for any debris, filaments, any mucin strands in the tear film. Take a look at the eyelashes where there is any trichiasis or any deposits. Is there any scraph or collarettes? Look for any kind of seborrhea, anterior squamous blepharitis, any distichiasis. Carefully load the anterior and posterior lid margins, any abnormalities of the meibomian glands. Look for the meibomian gland orifices, whether they're pouting, is there any cap meibomian ducts, or if you can compress on the lids if there's any kind of frothy discharge or any toothpaste-like expression from the meibomian glands. The usually thickened, turbid, foamy secretions or frothy discharge can be seen at the lid margins is because of the bacterial lipases which act on the lipids in the meibum, and the bacterial lipases saponify the fat in the meibum and cause this frothy discharge seen at the lid margins. Look for any keratinization at the lid margins, any telangiectasia. Carefully make a note of it in your notes. How do we quantify and diagnose a dry eye? Stability of the tear film, we do a TBUT. Of course, we don't do NIBOT, that is a non-invasive tear film breakup time. Look for the tear production. Here we do the Shermer's fluorescein clearance test. Of course, tear osmolarity is done in the lab, not a in-house or in-house office test. Look for any ocular surface disease. We take a look at them using the vital stains, the corneal stains, and we can do an impression cytology also, which can be sent for immunohistochemistry. The objective tests always are done in the same order. First, we look at the tear meniscus height, tear film breakup time, ocular surface evaluation with the vital stains. Here we use fluorescein, rose Bengal, or lissamine green, and give a good gap of 30 minutes and then do the Shermer's. Basically, we do the Shermer's 1 and then the fluorescein clearance test. Most of it is the in-house test, and all of us can do it and evaluate the stability, the tear production, and quantify the type of dry eye. Tear meniscus height, it's the distance between the upper lid and upper edge and the lower lid of the visible junction between the cornea and the lower lid. Usually the normal range is between 0.3 to 0.7 mm. In cases of severe dry eyes, if you've noticed, it will be less than 2 millimeters. Usually, I mean, you
Dr.
stain the-
Samia,
Yeah.
sorry to interrupt you, but we need to hurry up. So if you could.
Yeah, I will hurry up. Yes. Tear
Yeah,
meniscus
if
height.
you could just wind up.
Yeah. And next we do the tear film breakup time. Normal is 10 and mild to moderate is 5 to 10 and less than 5 is taken as severe. Look at the ocular surface staining pattern using fluorescein stains. You can do a dual staining with fluorescein as well as the glycerin green, and note the punctate staining pattern, whether they are diffuse, focal, punctate, or coalesced. You have the NEI system of grading for grading the cornea and the conjunctiva. Note the scores. This is the commonest one used. People use even Oxford School of Grading also. Next is the Rose Bengal staining, which, I mean, Vance Jewell scoring is used. Lissamine green also can be used. Please note the staining pattern of the cornea and the conjunctiva. Shermer's Watman's filter paper is used. This is how we do. Between the lateral 1/3 and the medial 2/3, the Watman filter paper is placed. Look for the wetting of the surface on the Watman's filter paper. Normal is between more than 15 mm. Severe is less than 5. After we have summated all this, look at the OSDI scores, summate everything. No single test is conclusive, lacks either sensitivity or specificity. Most of them are reproducible. Do a thorough clinical examination, do the tear film study and the severity panel, which is given by Delphi. The whole thing, after evaluating, this will help us, in conclusive diagnosis and management of your dry eye. Okay, probably it's not going to the next slide. Thank you, everyone, for the patient hearing. I think it was of some use. Anyway, I had to wrap up the last few minutes. Yeah, most of the tests are done. Nothing, a single test is not conclusive. Compile everything from your OSDI scores till your Shermer's and then evaluate your patients and then treat them. Thank you.
Thank you so much, Dr. Samia. It was a wonderful presentation, and dry eyes being so commonly seen nowadays, not only in the urban, but also the rural populations because of the screen time that has increased for everybody. Now we go to our next speaker, Dr. Samina Zaminda. She needs no introduction, but I can say that she's been a very, very close friend. She is very helpful. And whenever you think quality, not only in ophthalmology, but in the whole of medicine or anything, when you talk quality, the first name that comes to your mind is Samina. So she has done wonderfully in not only ophthalmology, but giving quality to all our services in the medical fraternity. Dr. Samina, just to give you a little more information about her, she is a very good cataract phacoemulsification surgeon. She has been awarded the Young Quality Achiever at the 4th International Conference of Consortium of Accredited Healthcare Organizations at Chennai on the 8th of April 2018. She is a registered assessor with the NABH. She has taken NABH to a different level. She has brought NABH into even the smallest of cities and villages. She has been the chief instructor for training participants on implementation of NABH standards at All India Ophthalmology Society Conference for the 3rd consecutive year. She started a knowledge sharing platform of which even I am a part of, Eye for Quality, where we share many things about quality, and we are doing continuous learning on that particular platform, which was started in August 2016 and is very, very active even today. Dr. Samina Zaminda has 2 centers now in Bangalore, and she's doing wonderful work. And over to you, Dr. Samina, for a presentation on giving quiet eyes after cataract surgery.
you, Dr. Shilpa, for that wonderful introduction. Thank you so much. And I think in interest of time, I'll share my screen now. I hope you're able to see my screen completely.
Yes, we can.
Okay, thank you. Thank you so much. जैसे तिल में तेल है, जो चकमक में आग, तेरा साई तुझ में है, तू जाग सके तो जाग. Friends, Kabir ke dohe, we've always heard from our childhood. And this is the essence of the dohe of Kabir. Just as a seed has oil and a spark is the essence of light, divinity lies within you. Realize this if you can. And each one of us today is having this seed, the spark. We're going to take it forward. I for Quality, the knowledge sharing platform, which Dr. Shilpa mentioned, is very much active. Under that, now we have a program known as Observe, Understand, and Change. And please do connect with us to learn more about it, to be a part of that. Now, I am going to talk about a quiet eye after cataract surgery. Postgraduate students who are here with us today, I want you to, just a small request. Tomorrow, when you go inside the operation theater, please do spend some time in your TSSU, theater-based sterile surgical unit. Please see how the soaking, the cleaning, the packing, the drying, and the autoclaving is happening. I strongly believe that any surgeon, not only an eye surgeon specifically, because you know our eyes are so sensitive, and toxic anterior segment syndrome is not, it's just right there. It can happen to any patient with the best of surgeons, with the best of techniques, with the best of everything. So what is STARS and why does STARS happen? There is this European Society of Cataract and Refractive Surgery guidelines of 2013, done by my mentor, Dr. Peter Berry, Data, Dilemmas, and Conclusions. And I would insist that each one of you, this is available on the public domain, please, this is like the Bible if you want to prevent toxic anterior segment syndrome. And it is a part of a surgeon's duty to ensure that the instrument, what they're using, the stuff, what they're introducing inside the eye of a patient is the correct thing. Because even if you might be a fantastic surgeon, but if you have not taken care of these things, you will end up having a very, very unhappy patient. So we at Zaminda's Microsurgical Eye Center are very, very particular about it. We have done a fishbone analysis of undue postoperative inflammation after uneven full phacoemulsification cataract surgery, and look at this detailed fishbone right here. Now, there is a key performance indicator in our center. What is the visual acuity on day one? The unaided visual acuity, the pinhole vision acuity, and the examination of the patient on the slit lamp is a must. Grading them with the sun classification is a must. So anywhere where we see an undue inflammation, it is a red alert. And we do investigate any such patient who comes with an excessive inflammation and see the details, what has to be checked. From the instruments, phaco tip dust, insufficient inventory, reuse of single-use instruments are not done, lack of policy or for documentation for sterilization, inadequate staff training, new staff, quality of water not checked, visco is trapped in the cannulas. The cannulas, what you use, do you understand it is so impossible to really clean these cannulas? We struggled with that for a while, and then now we are using disposable cannulas. Right? I'm being greedy today to share the knowledge, what we have learned, so that you enjoy happy patients. The disinfectant, just see what solution is used to clean your instruments. Are they using enzymatic detergents? There are some places where they use still Savlon. Please see that that Savlon bottle goes away from your operation theater. So these are simple things what can be changed. The final rinse of the instruments before they are set for drying should be done with RO water so that there is no mineral deposit. The instruments, when they come outside the operation theater, they should never be soaked in hot water. There'll be coagulation of the bioburden and it will be difficult to remove that. It will be always normal water or cold water, never lukewarm or warm water. And if you really want to use some solution to clean, then please use a non-enzymatic solution, right? So these are simple things what you need to understand. Surgery parameters. When you're doing phacoemulsification, I will be sharing with you what are the step-down parameters for phacoemulsification, which is going to ensure that the inflammation in your eye is less. And intracameral drugs. What are you introducing in your patient's eye? Is it checked? Have you checked the expiry date? Have you checked the solution, the BSS or the ringalectate, whatever you're using against sunlight or light, and seen that there is nothing which is there inside? So have you washed away the visco behind your intraocular lens? Imagine all these things are so important. Before we talk about the management of quiet eye, we should be foolproof in what we are doing with our patient's eyes. So this is the standardization of uveitis nomenclature, the sun classification, and this is a mandatory thing to be done for each and every patient on your scheduled day of post-op follow-ups, day 1, day 10, day 21. Flare and cells both. There is an Indian Journal of Ophthalmology paper about late recurrent uveitis after phacoemulsification. And 15 such cases were reported after an uncomplicated phacoemulsification with the in-the-bag IOL implant, right? So these cases were later on considered as non-infected and treated medically with good visual recovery, right? These are published in IGO, very readily available. So they did not have any further recurrences over 8 months. How often are we closely monitoring our post-op patients? Very important. How often are we actually looking at our post-op patients very closely on the slit lamp, grading them on the sun? And if there is one of such patient, the important thing over here is to see that we do a complete fishbone analysis, a complete root cause analysis for them. Because that one case, if neglected, can end up into a cluster of tasks. Remember that. If that one case which was neglected can actually become a huge problem for you, whether you are in private practice or community practice, wherever you are. You can see this hydrophobic intraocular lens in sulcus continuously rubbing against the iris, right? And this obviously is one of the very common reasons. So kindly, if you have to put a IOL in the sulcus, you cannot put a hydrophobic IOL. You should definitely avoid that. Persistent post-op inflammation, common causes, residual lens fragments, epinuclear or cortical material. That could be metallic debris from phaco probe. You need to know that how many uses you will do of the phaco tips. Phaco tip has to be changed with every single case, the tip and the sleeve, even if you're not changing the phaco probe. Rust from instruments and debris. So there has to be an operation theater policy that your OT staff is actually looking at all the instruments, maintaining an instrument inventory and checking the instruments under the microscope and discarding the instrument which starts to develop rust or giving them for servicing. Intraocular myotics and postoperative inflammation. I remember this very clearly in the earlier days of phaco people and, in the bag IOL implantation, people wanted to, use myotics so that, they will, the pupil should be constricted, round, small. My patient comes out of the operation theater and sees 6.6. Friends, how much is this advisable? I would definitely not advocate this because post-operatively, you get increased inflammation, right? And these are patients receiving carbachol intracamerally. Intraocular myotics and post-operative inflammation. Again, there was a comparison between with and without, and it is better to leave your patient alone and not worry too much about constricting your pupil on table unless it is a requirement of that particular case. Patching, patching of the eye. Fortunately, most of us now remove the patch within 1 or 2 hours because it has been very conclusively shown that if you patch the eyeball for a longer time, the inflammation increases. So please remove the patch within 2 hours and start the steroids and the antibiotics. On the day one, you will have a happier patient, lesser inflammation, lesser cystoid macular edema. Post-operative sterile endophthalmitis. I have already shared my own Bible, the ESERS guidelines by Dr. Peter Berry, 2013. If not for anything from my talk, if you just take that take-home message, I'll be glad. Trypan blue is a possible cause. Yeah, most of us use trypan blue in our surgeries, and please see that whether that is coming from a good vendor, right? It is our duty to ensure that the drugs what we use inside our anterior chamber are procured, stored in the correct manner and from a good vendor, a reputed company. The step-down technique with Dr. Abhay Vasauda pioneered very clearly says that you need to reduce the phaco settings as you go forward, and the last fragment, the vacuum and the flow rate should be less. This technique has one byproduct, a beneficial byproduct, that the inflammation is low. So these are some details of the step-down technique, but I'm sure that you will be able to find them on the public domain. And there has been a comparison, of course, between ringalactate and balanced salt solution. It is a no-brainer that BSS reduces the post-op inflammation. High and low aspiration parameters, randomized clinical trial, again by Vasauda's group, very clearly shown that low aspiration parameters results in lower inflammation rates. So there are guidelines for managing post-cataract surgery inflammation, and it is very, very important that we follow these guidelines. Since cataract surgery was first described, inflammation has been accepted as a natural consequence of the procedure, right? So enhanced surgical technique and with all other things, what I've said now will reduce the intensity of your inflammation. Prevention of inflammation is the goal, and this means good patient selection, good preparation, good surgery, and a good post-operative therapeutic regimen. We need to diagnose which are the patients which we would consider in a high-risk category, patients whom we have to closely monitor and enhance the post-op regimen. Some of the common ones are diabetic, uveitis, glaucoma, ocular vein occlusions, retinitis pigmentosa, macular edema, epiretinal membranes, juvenile rheumatoid arthritis, juvenile idiopathic arthritis, pediatric patients, patients with ocular surface disease, just like Dr. Samia told us now, compromised corneal epitheliums and corneal ulcerations. Later on, when these patients, after healing, go for surgery, we still have to be very careful with them. So for ophthalmic surgery, the sterilization, especially flash sterilization, should be used only where there is an emergency. Otherwise, a complete cycle sterilization is important, and there should be written down policy and protocols for all critical processes in the operation theater. The operation theater staff should have an ownership of the processes. Whenever you have a new staff joining your team, there should be training, and there should be a privileging can happen for them. Privileging meaning allowing them to do the work only after they are trained sufficiently. So standardization is important, cleaning, sterilization, quality of intracameral drugs, technique, parameters, post-op compliance with better formulation. I'm going to stop sharing this now, but I have another 3 minutes of your time to talk about something which is very, very important, and that is how do you take care of these eyes when they are not quiet enough? Please see this video to understand that how a surgical safety checklist, just this one piece of document, can bring a huge amount of difference in the way in which your operation theater runs.
This is a case sheet of Mrs. Mahadevamma. We are doing her right eye with 21.5 Oroflex lens. This is the lens, so we have kept it ready. And we also have a backup lens for the same. The lens has been checked. Patient safety is utmost importance to us. A part of patient safety involves safe surgery, which involves three components: sign in, time out, and sign out. Here's Mr. Navanita Krishnan, left eye, phaco topical temporal incision, 23.5 diopter, toric T4, 44.68, 99, 45.92, 93. Alignment is 6. Time out. Left eye, phaco topical temporal incision, 23.5 diopter, toric. Sir? Operation நல்லா ஆயிடுச்சு. சரிங்களா? நீங்க நல்லா இருக்கீங்களா? After the surgery is done, we make the patient sit and announce sign out, ensuring that the patient is stable and fit to leave the operation theatre, checking the vitals of the patient. In addition to what we have seen right now, we also, on the day of the surgery, ensure that all our equipments are working properly. We ensure the readiness for any ophthalmic complication and medical emergencies. And last but not the least, we ensure that all our instruments are sterile by checking the indicator strips of the orthopedic machine. I'm Rupa, OT in charge. I'm showing this unsterile blades. This unsterile blades, no, see, this is the chemical indicators. The color is not changed because this is unsterile. Here also color is not changed. And this one is autoclaved, sterile instruments. This indicator color is changed to blue to black. This also color is changed.
No surgeon, however careful, can prevent medical emergencies during surgery. Monitored anesthesia care and presence of an anesthetist becomes vital. So we have learned something from here that there are many, many things which your attention as a surgeon is needed for the successful surgery, not just your phacoemulsification surgery skills, right? We know that cataract surgery damages the ocular surface and it causes tear film instability. I'm thankful to Dr. Samia for already teaching a lot about tear film instability. Inflammation. Cataract surgery induces a surgical inflammatory response, disrupts the blood ocular barrier, causes the entry of inflammatory cells and cytokines into aqueous humor. The uncontrolled inflammation can lead to pain, patient discomfort, delayed recovery, suboptimal visual outcomes, and further complications like cystoid macular edema, posterior synechia, raised intraocular pressure, corneal edema, hyperemia, and photophobia. The chemical changes which happen are that the inflammatory cytokines are elevated in the tears post-cataract surgery. There is an increase in the IFN concentration after cataract surgery. The IFN producing inflammatory cell is mobilized to the ocular surface, and there is increased level of ribonucleic acid transcripts encoding IL-6, TGF, B1, and TNFE. Targeting tear inflammatory cytokines might decrease the ocular surface damage after cataract surgery. This is some new knowledge what we are having. The common complaints after cataract surgery: ocular discomfort, irritation, red or watery eyes, foreign body sensation, and fatigue. Intraocular complications seen in 8.3% of patients undergoing cataract surgery. What we need to understand is that achieving a quiet eye after cataract surgery is a challenge because of the adverse structural changes, inflammatory changes, and chemical changes, especially if all what we already discussed has not been given attention to. So we have to look at the corneal integrity. We do not want redness, we no complaints of discomfort without irritation of the conjunctiva or the sclera. How is that possible? The guidelines for treating high-risk patients. If you remember in the beginning of my talk, I did share about the high-risk patients. What do you mean by a high-risk patient? And there should be a stronger regimen to take care of high-risk patients, right? Your post-operative steroids and NSAIDs should be stepped up. The important thing for you to understand is that the patient should be encouraged to keep a 15 minutes gap between the corticosteroid, your prednisolone, and your NSAID drop. Very important to keep a 15-minute gap, and looking at the dry eyes at the same time. All these drugs have a preservative, and the preservative can be a complete spoiler, and you need to look at that. Very, very important. The post-cataract surgery aim is to have a quiet eye by controlling inflammation and maintaining surface integrity. Both the things simultaneously. Modern IOLs demand a good post-op regimen. You have put a premium intraocular lens. The patient has so many expectations. This is all about matching patients' expectations. Have you preoperatively looked at the dry eyes? Have you taken steps to reduce inflammation? There are many, many, many such points, and you need to always be on the top of the situation to get the best outcome from your intraocular lens. Non-steroidal anti-inflammatory drugs are commonly used. We at our center use these drops 3 days before the surgery, 3 times in a day, and then discontinue it immediately after surgery, but start again on the day 21 while the steroids are getting tapered. Now, these non-steroidal anti-inflammatory drugs are effective, but there is a but. The preservative in the non-steroidal anti-inflammatory drug can cause dry eyes. So along with that, you need to understand that these preservative, the surface integrity is getting compromised. You have to be very watchful of the patients on whom non-steroidal anti-inflammatory drug is going on for a long time. Let's talk a little more about the preservatives which are available and the dose-dependent effects of the most common preservative, the benzalkonium chloride. Look at this. From 0.04% to 1 to 2% in animals, how much it can cause, what havoc it can cause on the eyes. So what is the alternative? The alternative is definitely a purite preservative, something which has a stabilized oxychlorocomplex oxidative ophthalmic preservative. And this is bactericidal, fungicidal, and virucidal properties, and no documented toxicity to mammalian cells, does not induce cellular damage. Purite formulations are suspensions formulated using micronized particles, prevents irritation or scratching of the cornea, maintains surface integrity, pre-pierced plastic container with easy to open containers. So purite dissipates into components normally found in tears. Hence, the clinical advantages are there. It's less epithelial toxic, improved tolerability profile, and better patient compliance. The summary, as I would like to say, is achieving quiet eye after cataract surgery is important. Of course, we know that topical NSAIDs are useful to control inflammation to achieve quiet eye. However, preservatives present in the topical formulation can cause adverse effects. Among the preservatives, bark has been shown to cause tear film instability, loss of goblet cells, conjunctival squamous metaplasia, apoptosis, disruption of corneal epithelium barrier, and damage to deeper ocular tissues. Purite is a novel alternative to chemical preservatives. Friends, I hope that you have understood that it is more important to take all possible care to achieve a quiet eye naturally than to struggle with any more medicines post-operatively. So take good care of yourself, and let's hope that together we learn many more things today. Thank you so much, Dr. Shilpa, and I'm sorry if I have extended my time, but I'm thankful for your kindness. Thank you so much.
No, Dr. Samina, it's always a real joy to listen to you. You give a completely new dimension to whatever we have been doing, probably without even thinking what we are doing, but you give a different perspective altogether. So it was a wonderful presentation and a lot of take-home messages, very, very simple things that we can incorporate in our everyday practices. Thank you so much, Dr. Samina. Now we move on to our next speaker, Dr. Hemlata. She is presently working as assistant professor at Keynote Eye Hospital. She is a retina consultant. She was also working at Lions Eye Hospital, and she's done her fellowship in vitro retina from Shankar Nethralaya, Chennai, and has also done the Ratan Tata FECO fellowship from Shankar Nethralaya. Over to you, Dr. Hemlata, and I request you to stick to time. We are running a little late, I'm sorry, but please do that. Thank you so much.
Thank you, ma'am. Thanks for such a nice introduction. I would like to thank Dr. Samina Zaminda, ma'am, for giving me this opportunity to present in this vast program. And a special thanks to our beloved director, Dr. Sujata Rathod, for giving me this opportunity to be a part of this program. My slides are visible, ma'am?
Yes, yes, they are visible.
Okay, thank you. So today's my topic is to discuss about the 10 common conditions, retinal conditions, which we come across in our day-to-day OPD. So the most common thing in the retinal clinic which we see is retinal detachment. So related to this, I'm going to brief about some of the case scenarios. And as we all know, the incidence of RD is around 5 in every 1 lakh patients, and in elderly population it's around 20. The lifetime risk is around 1 in 300, and in younger population, it's more seen in myopic patients, that is myopia of greater than 5 to 6 diopters. Here, the retina is thin and stretched, so the risk is high. We all know about the basics of the symptoms of RD. Usually, the patient present with sudden onset of painless decrease in vision, photopsia, that is flashes of light, and sudden increase in the black spots in the field of vision, and maybe a loss of field of vision. And if associated with trauma, there may be pain as well. Signs, like any patient we evaluate, initially we need to look for visual acuity, pupillary examination to look for any RAPD, and visual field testing, and also IOP monitoring and checking as a primary is very important, because compared to the affected eye, unaffected, there will be a difference of 5 mm. And slit lamp examination, not to miss mild iritis, and you can see on a slit lamp tobacco dust appearance. These are all which is a sign of RD, and there may be cobweb like collagen fibers. So a fresh RD, how do a fresh RD looks like? We all know about that convex and the fresh corrugations we can see, and whenever there is a loss of vision or a mild loss of vision, we can confirm with the OCT the detachment of the fovea as well. So PVR, if we don't intervene at right time, the PVR changes can be graded to A, B, and C. In C, there will be fixed retinal folds and vitreous condensation. And if the patient is being not treated, then we'll land up a picture like this, where there is an atrophic retina with subretinal bands and total loss of photoreceptors. So today I'm going to brief about some of the clinical conditions where we come across in our routine OPDs. So there is an entity called subclinical RD. So we know that according to a definition, most of these tears will be anterior to the equator, and there will be less than 2 disc diameter of SRF. So if the media is clear, we can go for the barrage laser, and in this picture we can see the barraged subclinical RD, which is well confined, and it has not allowed the RD to progress. And as these patients may be having a good vision, a thorough peripheral retinal examination is very important. If the media is hazy due to cataract or PCO or diffuse VH, like a PVD induced VH, then a B scan also helps us to diagnose subclinical RD. Here you can see an HST, and a PVD will be attached to the anterior flap of an HST, and this is a small cuff of SRF. The next condition is myopia. So in myopic eyes, the most common degeneration we see is lattice degeneration, common site being superotemporal aspect, and high myopes, especially -6 diopters and above, and axial length greater than 26 mm, the risk of RD increases 5 to 6 folds. And although these patients comprise only 10% of the general population, there will be 40% risk of the RD among them. So the complications which may occur is, in a lattice degeneration, there may be atrophic holes, or there may be acute PVD induced tears at the edge of the lattice. If we diagnose a lattice, especially when subjecting the patients for any surgical intervention like cataract surgery or refractive surgery, it's better to barrage it, prophylactic barrage, and then proceed for the surgery. If a lattice associated big tear with total RD, then we may have to go for the vitrectomy surgery. Next comes hypermetropic eyes. In hypermetropic eyes, like the retinoschisis, the incidence of RD is around 2.5%. Here there will be splitting of the neurosensory retina into 2 layers, and in the macula you may see a cartwheel appearance, and these are all the outer retinal holes, and sometimes in the extreme periphery of the schisis area you may see a opacified vessels. So very important to see the retinal examination with indentation. And the common site we all know is inferotemporal aspect, and usually the B scan picks up a single spike dome shaped elevation as seen here. And the OCT picks up the palisade vertical cystic degenerative changes. This is the cartwheel appearance. If you see an OCT along with this degeneration and SRF, then we have to think, is there any possibility or a progression to an RD? So you see a corrugation here as seen here, and this is the outer retinal holes, and these are all the bigger size, and whereas the inner retinal holes are smaller size. Whenever there is both outer and the inner retinal holes, then these patients develop hardy and they become symptomatic. That time we need to plan for the surgery. The next common condition we see is cataract and RD. And we know the incidence of PVD around 60 years is around 10%, and 7th and 8th decade it increases 30 to 60%. So most of the patients with cataract surgery, it's very important to see the retinal examination. If the media is totally opaque, like mature cataract, hypermature cataract, then we have to go for the B scan. And also here you see a total RD with a near closed funnel in the posterior aspect. So whether we are dealing with an RD with complicated cataract or cataract with the RD. So this has to be evaluated. And also patients with myopes. It's very important to do a B scan before cataract surgery. See here you can see a posterior staphyloma. So whenever the postgraduates will be giving block, so we need to instruct them about the careful block and also the status of the PVD. Is there any diffuse vitreous hemorrhage? So it helps us to prognosticate the vision. And we know the first year post-cataract surgery is a crucial for follow-up, as 50% of the pseudophakic RD presents within the first year, especially if they had a complicated surgery like posterior capsular dehiscence or vitreous loss, and post-YAG capsulotomy as well. The characteristic of pseudophakic RD is like the progression is fast, there will be multiple tiny breaks in the periphery, so localization of breaks will be difficult, and they are high risk of PVR changes, so we need to intervene early. The next clinical cases which we see is trauma. So these are all the challenges. As we know, trauma can cause RD like retinal dialysis or giant retinal tear, but a condition like this with total subtotal hyphema, traumatic iritis, a lid hematoma, subconjunctival hemorrhage, and vitreous hemorrhage, all these things may not allow us to see the retina in detail. But in these conditions, it's important to evaluate the other eye. So if the other eye with a clear media, not to miss white without pressure, because we know these are the eyes which are prone for GRTs, giant retinal tears, and also studies have proven aphakic and pseudophakic lens status also, like the risk of RD is more among aphakic and pseudophakics compared to phakics. So in this patient, there is a GRT, you can see here, this is the posterior flap and an anterior flap. And if the GRT confined to nasal aspect, they may have a good vision as well. So vision is not the criteria. And here you can see in the B scan, the anterior and the posterior flap of the GRT, retinal tear. And these trauma cases, while prognosticating the vision, associated trauma has to be kept in mind, like severe Berlin's edema, subretinal bleed, choroidal rupture, and macular hole. So if we diagnose early like this, we can go for the barrage laser. If the GRT is associated with the macular hole, then we may have to go for vitrectomy surgery. This is another patient, 6-year-old boy with a cricket ball injury. And most of them may not have a loss of vision, but if we miss the diagnosis of retinal dialysis, like slowly they come with RD. So very important, these patients to follow up, and ora to ora fundus examination is a must, and also pupillary examination every visit of follow-up. And also we need to keep in mind the possibility of traumatic optic neuropathy in these patients. So this is a patient who underwent the buckling procedure, been diagnosed within 2 weeks, and then this is the post-buckling procedure, non-drainage, the patient vision being resolved. The next condition is CD. Sometimes in the clinical thing, especially when we get a reference from filtering surgery like glaucoma surgeries, we may see a dome-shaped elevation like this because of hypotony. So here I would like to just make a point to see, is there any breaks over these CDs? This is also very important, because along with managing the hypotony, in case if there is a break, we have to expect once the CD resolves, the RD will set in. So then we have to plan for the RD surgery in these cases. The next condition is diabetic patients. So we all know about the basics of diabetes. There will be new vessel formation and proliferation of fibrovascular tissue, which leads to tangential traction, anterior-posterior traction, and a bridge traction. And OCT also important to look for vitreomacular traction so that we can plan for the surgical intervention. So if you come across a diabetic cataract like this with total cataract, and if there is a vitreous hemorrhage, to know about the retinal status, we can go for the B scan. This is a multiple schisis of the vitreous, vitreoschisis, or is there any TRD as seen here, concavity with incomplete PVD, or there is a complete PVD with combined RD. So accordingly, we can plan for the surgical intervention. So this is a picture of OCT where there is multiple vitreoschisis with vitreomacular traction, peripapillary area. And this is a slit lamp. We can confirm the old RBC cells. And here there is a small hole at the base of the prolif. So usually the breaks will be at the base of the traction. The next clinical condition is exudative RD. So as I already stressed, any posterior segment case, the examination should not be confined to posterior segment. We have to go from the anterior, not to miss any granulomatous or uveitis features and inflammatory cells in the anterior vitreous. A dark room examination with high magnification is very important, and then go for the fundus evaluation. And if you can see a convex, smooth elevation of the retina with the shifting of the fluid. If the patient is associated with pain and there is RCT thickness being increased and early T sign, then posterior scleritis, and B scan helps to differentiate any tumors, the amount of inflammation, and the axial length measurement to rule out any nanophthalmus or small eye. And this is a fundus picture of multifocal CSR. You can see inferior exudative RD, and on FA you can fit the multiple leaks of the CSR patient. And this is a picture of VKH. So in VKH you see hyperemic disc, and there may be a subtle RD, pinpoint leakage on FFA, and this is the bacillary membrane detachment at the interdigital zone and RP undulations. These are characteristic findings of VKH. And even the other eye is normal. You know, VKH is a bilateral condition. Make sure you do a B scan. Even the media is clear to look for RCT thickness and OCT. You can see early changes which is setting in here with RP undulations, and a B scan in the periphery, not to miss the exudative RD at the early stage. And this is the RCT thickness which is being increased in this patient. The next clinical entity of exudative RD is uveal effusion syndrome. We will not go in detail. Leopard spot appearance, and the treatment, we know we need to decompress the sclera by creating a scleral window or vortex vein decompression. And the next is, we do get a lot of reference from anemic retinopathy, like from the Victoria Hospital or from Vani Vilas. So along with the anemic retinopathy changes, that is multiple ILM bleeds will be there, rod spots will be there. If we see a picture like this of disc edema, pale especially, think about vitamin deficiency, like B12 deficiency can also present like this. The anemic picture may be associated with hypertensive changes, and sometimes in preeclamptic patients we may see a exudative RD. And also very rare, but we have to keep in mind to look for the vitreous, any tumor cells. These patients may be associated with leukemia, ALL and CML with ONH infiltration as shown here. The other common tumors which may present with exudative RD are choroidal hemangioma because of increased vascularity, choroidal melanoma, metastasis, hemangioma, and Coats disease. Thus, the prognosis, we all agree, the early intervention, at least 40% of them, we can give them the reading vision. Once macula will be affected, only 30% gets back the reading vision. The more severe the detachment, the longer the duration, the worse the prognosis. And to conclude, recognizing and treating all the retinal condition at the earliest is a must. Knowing the risk factors in each clinical condition, anticipating the possibility of RD helps us not to miss the diagnosis in any case scenarios. Meticulous clinical examination and follow-up is a must, and educating patients who are all at risk of RD should be a part of our OPD routinely. I would like to thank Team Minto and our Retina department staffs and postgraduates for helping me out. Thank you all.
Thank you, Dr. Hemlata. That was a wonderful presentation. In fact, an eye-opener for anterior segment surgeons that so many things can coexist when there is a cataract. Thank you so much. Now we go on to our most awaited session, which is the competitive session. I request the judges, Dr. Suma Krishna, Dr. Rita Gangwani, who will be judging the retina papers, Dr. Samia Bassan for cornea and ocular surface, and Dr. Divya, who is cataract and oculoplasty surgeon. I welcome you all judges to this session, and just to give a brief introduction of each one of you. Dr. Suma Krishna completed her MBBS from Karnataka Medical College, Hubli, and did her post-graduation from Arvind Eye Hospital, Madurai. She did an International Council of Ophthalmology Fellowship in uveitis at Germany. Her area of special interest is medical retina and uveitis. She has been working with Zaminda Eye Center as a medical retina consultant since August 2015. Dr. Rita Gangwani, she is currently a medical retina consultant at Ahmedabad Eye Laser Hospital at Ahmedabad. Her professional experience has been that she has done her fellowship in vitreoretina at Retina Foundation under Dr. Nagpal. She has also done her clinical tutorship at the Department of Ophthalmology at the Chinese University of Hong Kong. She's been a clinical assistant professor also there, and she has many publications to her credit. The Dr. Suma Krishna and Dr. Rita Gangwani would be judging the retina papers. Now, Dr. Samia Bassan, I've already introduced you to. She is a cornea specialist and also doing ocular surface work. Dr. Divya is a cataract and oculoplasty surgeon. She is presently working at the Ramaya Medical College and Hospitals, Bangalore. She has done her post-graduation, that is DO from Arvind Eye Hospital, Madurai, and DNB from Lions Super Specialty Eye Hospital, Bangalore. So I invite all you judges, and we go on to our fellows who will now be presenting each of their cases. I invite Dr. Kusuma. She is from Minto Eye Hospital, and her mentor is Dr. Shweta M. Dr. Kusuma, are you ready?
Yes, ma'am.
Yes.
Dr. Shilpa, thank you so much for moderating this session extremely well. And I hope everybody is alert and all ready now to listen to our young students presenting and fighting it out in this competition round. I'm so glad that we have got an amazing faculty as judges for this session. And just so that everybody knows that you will be judged on the following criteria. Criteria number 1, the uniqueness of content. So each judge will score you between 1 to 10. Now, you have to, for Dr. Shilpa will be able to also tell in what category that case is in the beginning, so that those judges are alert, right?
Yeah.
So please, even the participant, please just share in which category you're presenting: retina, cornea, oculoplasty. So those particular judges will be alert, and you'll be scored between 1 to 10. In uniqueness of content, completeness of the case, whether you have got all the complete data. The third is learning points. What were the salient learning points? And if you're very clear about it, again, between 1 to 10, you will get a score on that. And timeliness. If you complete within 5 minutes, you get a complete 10 out of 10, right? So remember that, and all the very best. Over to you. Thank you again, all the judges, and just wanted to thank Dr. Hemlata for a wonderful, wonderful presentation. Thank you so much.
Thank you, ma'am. It's our pleasure to be part of your program.
Dr. Kusuma?
Yes, ma'am.
Yeah, can you now share your presentation? I think don't go into the slideshow mode because the slides are not going ahead.
Okay, ma'am. Good morning, everyone. I'm Kusma, a postgraduate from Minto Ophthalmic Hospital, Bangalore. My mentor is Dr. Shweta Hem. I'm dealing with the case belongs to cornea section.
Oh, sorry to interrupt, Dr. Kusma. I don't think all of us can hear you very clearly.
Hello. Hello.
I think you have to step up your volume.
Now, ma'am.
No, still it's very feeble.
Now, ma'am. Hello.
I don't know. What about the rest of them? I hear it very feebly.
No, we are not able to hear clearly.
Hello.
Increase the volume. Are you on the phone? Kusuma, are you on the phone?
No, ma'am.
Then increase the volume of your laptop.
Yeah, ma'am, I increased.
All right, go ahead. Talk loudly, please.
Hello.
Yes, go ahead.
Hello. Here is the demographical data. A 62-year-old male patient present with pain, redness, watering, and diminution of vision in the right eye since 15 days. And there was no history of trauma, no history of pain or swelling in the joints, no history of fever, ear and nose infection, no history of breathlessness or cough, no history of weight loss, no history of difficulty in swallowing or dry mouth, no history of chronic skin lesions, no history of similar complaints in the other eye. In the past history, no similar complaints in the past, and there is no history of diabetes, hypertension, and stroke history. And the family history is nothing significant. Personal history, the diet is mixed diet, appetite is normal, sleep is sound, bowel and bladder habit is normal and regular, habits are nil. Going to the general physical examination, here is an elderly male, moderately built and nourished, well oriented to time, place, and surrounding. His vitals are pulse rate is 82 beats beats per minute. Blood pressure is 122 by 84 millimeter of mercury measured in supine position, and respiratory rate is 16 cycles per minute. No pallor, icterus, cyanosis, clubbing, and lymphadenopathy. On coming to the systemic examination, the respiratory CVS and parabdomen CNS are normal. Coming to the ocular examination, the head posture is normal, the facial symmetry is normal, forehead and eyebrows are normal, ocular posture is orthotropic. We come to the visual acuity. In the right eye, the distant vision is 6 by 60, and in the left eye, it is 6 by 36. On pinhole, the vision improvement is 6 by 24 parts in the right eye, and it's 6 by 18 in the left eye. The near vision is N12. On after correcting with plus 2.5 diopter spherical, it is improving to the N6 in the right eye, and in the left eye it is N12. Plus 2.5 diopter spherical, it improved to the N6, and the color vision is normal in both the eyes. On finger confrontation, it is normal in all quadrants in both eyes. Refraction done under tropicamide at two-third distance. And vertically, it is plus 2.5 diopter spherical, and in horizontal, it is plus 2.5 diopter spherical in both the eyes. On best corrected visual acuity, plus 1 diopter spherical, it is improving to the 6 by 12. Even in the left eye also, it is improving to the plus 1 diopter spherical at 6 by 12. The projection of rays are accurate in both the eyes, and the position of the eyelid, the position of the lids normal in both the eyes, movements are normal, and the lid margins, eyelashes, skin of the lid, and palpebral aperture are normal in both the eyes. And the lacrimal apparatus, the puncta is normal in both the eyes. The regurgitation test is negative in both the eyes. Lacrimal syringing is patent in both the eyes. Coming to the conjunctiva, then bulbar conjunctiva, it shows ciliary congestion in the right eye, but it is normal in the left eye. The upper and lower palpebral conjunctiva shows diffuse congestion, but in the left eye it is normal. Coming to the sclera, there are multiple pockets of scleral thinning over superior and nasal aspect. There is superior and nasal aspect, the scleral thinning is present, superior and nasal aspect. This is the anterior segment of the right eye of the patient. And even the cornea, in sclera of the left eye, it shows old patches of scleral thinning noted in the inferotemporal quadrant. Coming to the cornea, there are whole yield peripheral keratitis lesion in the inferotemporal quadrant seen in the left eye, but in the right eye we can see the corneal thinning from 2 o'clock to 5 o'clock position in the nasal side. The sensations were intact in both the eyes. On doing Sharma test, it is 10 mm in both the eyes. On tear film breakup time, it is less than 10 seconds in the right eye and 10 seconds in the left eye. Anterior chamber, the depth of the anterior chamber is the normal depth in both eyes, but there is a flare present in the right anterior chamber depth of the right eye. It is flare plus 2 grade. Content is optically clear in both the eyes. Color of the iris is brown in both the eyes, and pattern is normal. The pupil, coming to the pupil, the pupil is single, 3 mm, round shape, and central in position in both the eyes. Pupillary reaction, direct light reflex and consensual light reflex is present in both the eyes. Swinging flashlight test, there is no RAPD. The near reflex is normal in both the eyes. Lens position of the lens is normal, and shape and is normal. Transparency, there is a nuclear sclerosis grade 2, cataract is there, and the extraocular movements on is normal in both the eyes. The ductions and versions are normal in both the eyes. The intraocular pressure is 16 mmHg in the right eye and 14 mmHg in the left eye. It is done using applanation tonometry. On fundus examination, the distant direct ophthalmoscopy shows red glow in both the eyes. Fundus examined by indirect ophthalmoscopy and 20D. The media is clear in both the eyes. The disc shows normal in size, shape with well-defined margins with cup disc ratio of 0.3, healthy neural retinal rim, and ISNT followed in both the eyes. Vessels are normal, and arteriovenous ratio is 2:3. The macula shows foveal reflex present in both eyes, and the background and periphery is normal. So the summary here is a 62-year-old male patient presented with watering redness and painful with the diminution of vision in the right eye since 15 days. It's going favor to considering the anterior segment examination showing the scleral thinning and corneal thinning in the nasal side. So I'm keeping in the diagnosis as necrotizing scleritis with peripheral ulcerative keratitis. Based on that, I have done investigation, the complete hemogram, renal function test, and liver function test, Mantoux test, and C-reactive protein. everything came normal, but the ESR is 60 millimeter per hour. The autoimmune antibody profile like ANA, rheumatoid arthritis, and C ANCA and P ANCA were done, which were negative, and the chest X-ray was normal. And later patient was sent to ENT to get ENT opinion to rule out any uh, polyps in the nose or any ENT regarding infections. And even after ENT findings which were normal, then we started him on IV methyl prednisolone. After getting the physician fitness, 1 gram in 500 ml NS was given for 3 days, followed by oral tablet prednisolone 60 milligram was started, along with lubrication CMC 1% drops, with the topical prednisolone acetate 1% eye drops hourly, along with cycloplegics omotropine eye drops thrice a day. Even after giving the treatment, there was a progressive thinning of sclera and the peripheral cornea is noted. So we sought an emergency immunologist advice, and we sent the patient to get investigations done under the influence of immunologist. They advised to give intravenous cyclophosphamide 900 milligram in 500 ml NS for every 4 weeks up to 3 months. At 6 months of follow-up, there is a complete resolution of scleritis with the scarring of peripheral cornea, and post-treatment vision is improvement to 6/18 in the right eye. This is the after 6 months follow-up patient. It's showing there is a yield peripheral ulcerative keratitis, and also there is a healing of the sclera, the blue hue showing that fibrosis scar, healed scar.
Dr. Kusma, are you done?
Yes, ma'am.
At the 6-month follow-up, if at all, have you forgotten to check any other parameter apart from the vision? Or have you checked and you have not mentioned it here?
Ma'am, RBS blood sugar level we should check.
Not systemic, ocular complication. If you're, if at all necrotizing scleritis can present with what as a late complication?
Staphyloma formation.
Pardon me?
Staphylomas.
Staphylomas, yes, because of the thinning. Apart from that, did you look for uveitis, cells and flare? Initially, you have documented it, and later on, did you check for IOP? Because glaucoma can be a complication of necrotizing scleritis. And what is the mechanism involved if at all there is glaucoma?
All that inflammatory exudates will go on the
that is one mechanism. Okay.
And even the fibrosis which causes angle become narrow because of the fibrosis of the
fibrosis. Okay. Anything else? There can be another mechanism because of the sclera being involved. There can be scleral edema and inflammation causing raise in the episcleral venous pressure, causing raise in the intraocular pressures. Was it documented?
Ma'am, in the follow-up, I documented, ma'am, that IOP is normal only, ma'am.
Yeah, it becomes important to mention it. Please, next time, please mention it.
Okay, ma'am.
Okay, and you go back to your ANA profile and please enumerate what are the different tests done to rule out. What all did you rule out?
I have done autoimmune antibody profile to rule out.
Yeah. Please start enumerating each one of them. ANA is done for what?
Ma'am, to rule out any collagen connective tissue disorders.
Like?
Like mixed connective tissue disorders, like vaginous granulomatosis.
No, not vaginal. Venous granulomatosis is a vasculitis.
Systemic lupus erythematosus.
No, ANA is done to rule out SLE, sclerodermas, Sjogren's.
SLE, systemic lupus erythematosus.
Yeah. And your RA factor?
for rheumatoid arthritis, ma'am.
Yes.
And C Anka is for polyarthritis nodosa, and that is collagen vasculitis.
C Anka is not for PAN. P Anka is for PAN. C Anka is for?
P Anka is for vaginous granulomatosis.
C Anka, yes, is for vaginous granulomatosis.
And P Anka.
And why did you send the patient to a ENT specialist? To rule out what?
To rule out any nasal polyps or ulcerations in the.
Ulcerations in cases of vaginous granulomatosis, PAN, polyarthritis nodosa, you can have any saddle nose deformities and tracheobronchial cartilages. Relapsing polychondritis can involve the pinna of the ear as well as the tracheobronchial cartilage. So if there is any stridor or anything, any tracheobronchial cartilage involvement, that's what you have to rule out. And what did you rule out on an X-ray?
Mom, X-ray, we have to rule out the upper respiratory in lung cavities there or not. We have to look for in vaginous granulomatosis.
Cavities are seen in which condition?
In vaginous, ma'am.
Can involve the lungs as well as tuberculosis also and sarcoidosis. All these can be ruled out using the chest X-ray. And what did your renal function test? What did you interpret from that?
Mom, in vaginous, it affects even kidney, renal system also. So we should send for RFT and serum electrolytes to look for whether any rise in serum, creatinine or urea level.
Okay, in cases of vaginous granulomatosis. Okay, why after you have started him on oral methylpred, right?
Yes.
And there was no improvement. So he was referred to an immunologist. What is, cyclophosphamide is given as a drug of choice in which condition?
Ma'am, in vaginous, they'll give.
Vaginous. Did you discuss with them why did they start him on cyclophosphamide?
Ma'am, they also not.
Not sure? Okay. What is the role of any topical drugs in cases of scleritis?
Ma'am, it reduces the inflammation, ma'am, topical.
No. I'm saying the choice of drugs. Do you use anything in cases of scleritis? See, you have a combination. You have a POK as well as scleritis.
Yes, ma'am.
Did you use any prednisolone drops?
Yes, ma'am. We use antibiotic.
Any immunomodulators were used?
No, ma'am. We started him on a direct systemic.
Cyclosporins or tacrolimus?
No, ma'am. Not.
Okay. Yeah.
Okay, now I think we go on to the next participant. One request to all the participants, please make sure you finish your presentation in time. It carries marks. So very, very important. And now we have the next participant, who is Dr. Vidyashri from Minto Eye Hospital again. Her topic is orbital schwannoma. The mentor is Dr. Chinmay. So request Dr. Divya and Dr. Suma and Dr. Gangwani to be judging this.
Ma'am, Dr. Shilpa, sorry to interrupt, but will you be telling us whether they have stuck to the time? Because we
Yes.
are not, okay, you will tell us.
Yes, I will tell you. I will tell you. Yeah.
Thank you.
Dr. Vidyashri.
Good morning, all. Myself, Dr. Vidyashri, and I'll be presenting the case under oculoplasty.
1 minute, can you make it a slideshow?
Go ahead quickly, you're losing time.
Ma'am, is it visible now?
Yes.
Yes.
Good morning, all. Myself, Dr. Vidyashri, and I'll be presenting case under oculoplasty. Here is a 16-year-old female patient named X, is a student hailing from Gulbarga. Her chief complaints are protrusion of the left eye since 5 years and diminution of vision in the left eye since 4 years. History of presenting illness. Patient noticed outward protrusion of the left eye since 5 years, which was insidious in onset and gradual in progression. associated with diminution of vision for both near and distance in the left eye since 4 years, which was insidious in onset and gradual in progression. Protrusion does not, and she also says that protrusion does not increases in size on cuffing, straining, or bending forwards. There is no history of double vision, no history of pain, redness, and discharge, no history of any previous ocular trauma, no history of palpitations, tremors, excessive sweating, or heat intolerance, no history of weight loss or loss of appetite, no history of fever and headache. Past history, she gives a history of similar complaints in the left eye 3.5 years back, and she consulted LV Prasad Eye Institute, Hyderabad. Patient clinically diagnosed to have left eye orbital lymphangioma and orbital debulking surgery was done. 12 doses of injection IVMP was given, and now she complains of similar complaints now. Histopathology sample was sent and the report was consistent with orbital schwannoma. Patient then lost follow-up since then. She is not a known case of diabetes, hypertension, asthma, thyroid, or tuberculosis. Family history, there is no such similar complaints in other family members. Personal history, diet is mixed. She has good appetite, adequate sleep, bowel and bladder habits are regular and normal. General physical examination, here is a 16-year-old female patient, moderately built and moderately nourished, conscious, cooperative, well-oriented to time, place, and person. There is no icterus pallor, cyanosis, clubbing, lymphadenopathy, and edema. But we noticed a neck swelling, but on noticing there was a neck swelling in the left submandibular region, which was measuring around 2.5 into 2.5 centimeter, which was mobile and firm in consistency. Pulse was 92 beats per minute, regular rhythm, good volume, normal character. Condition of the vessel wall was normal. BP was 100/70 mm of Hg, measured in right arm in sitting posture. Respiratory rate was 20 cycles per minute. It was thoraco-abdominal type. Systemic examination, it was within normal limits. Coming to ocular examination, head posture was normal. Facial symmetry, there was proptosis noted in the left eye. Ocular posture, left eye exotropia secondary to proptosis. Here we are showing the clinical photographs of the patient. First photograph, it shows when patient was 8 years old, and now present clinical photograph, it is shown in the right side. Coming to the anterior segment examination, distant vision in the right eye was 6/6, near vision was N6, color vision contrast sensitivity was within the normal limits, best corrected visual acuity was 6/6, orbit was within normal limits, and distant vision in the left eye was counting fingers at close to face. Near vision, color vision, and contrast sensitivity we could not assess, and even the refraction. Best corrected visual acuity was CF at CF. And orbit, there was non-axial proptosis was seen in the left eye. Coming to proptosis examination, on inspection, left eye appears to be proptosed outwards and downwards. Fullness is seen in the superomedial aspect of the left eye. Skin over the left eyelid appears normal. There was mild lag of ophthalmos was present. No periorbital inflammation, and proptosis doesn't increase on bending forwards or on Valsalva maneuver. In palpation, we inspected findings were confirmed. There was no tenderness and no local rise of temperature. Fingers can be insulated between the globe and the orbital margins. There was no thrill. Retropulsion test was positive. There was no infraorbital and supraorbital anesthesia. There was no enlargement of the regional lymph nodes. Auscultation, there was no bruit heard. Measurements. In the right eye palpebral aperture, vertically it was 10 mm and horizontally it was 30 mm. Axially it was 15 mm. Horizontal measurement it was 25 mm. And vertically it was 25 mm. But in the left eye, palpebral aperture was 35 mm horizontally, and vertically it was 16 mm. Axial measurement was 27 mm. Horizontally it was 50 mm. Vertically it was 27 mm. Eyebrows, in the right eye, it was normal. Lids were normal. Lacrimal apparatus was normal. In the left eye, eyebrows were normal. Lids, coming to lids, skin and position were normal. Moments there was mild lag of ophthalmos noted. Lid margins were thickened and eyelashes were normal. Lacrimal apparatus was normal in the left eye.
Your 5 minutes are up. Just one more minute.
Conjunctiva, sclera,
just
cornea.
say what are the positive findings.
Okay. In the left eye, there was a muddy conjunctiva with the dilated episcleral vessels on the bulbar conjunctiva. Cornea, there was cornea surface in the lower 1/3 of the cornea. Surface was irregular, sheen was normal in the upper two-third of the cornea, and sensation was present. Transparency was hazy in the lower part of the cornea. AC was normal. Pupil, there was 6 mm round pupil was present in the left eye, which was non-reactive to light. Both direct and indirect reflexes were absent. Lens was normal. IOP was 24 mm of HD measured with sublumination tonometer at 12:30 p.m. There was restriction of all eye movements in all positions. It is a fundus photograph of the left eye showing disc edema with retinal edema in the inferior temporal arcade with multiple cottonwool spots. Summary, here is a 16-year-old female patient presented with a history of protrusion in the left eye since 5 years associated with a diminution of vision, and she also gives a history of similar complaints in the past. Differential diagnosis mine will be optic nerve carcinoma with compressive optic neuropathies and mets in the orbit. Investigation CBC, peripheral smear, ESR, RBS, chest X-ray, CT, MRI, carotid angiography, orbital venography, and FNAC. Here the MRI here it shows the MRI report of the patient. A relatively well-defined T1 iso-intense and T2 hetero-intense lesion measuring 2.2 into 2.9 into 3.2 centimeter. It is noted in the superior medial aspect of the extracorneal compartment, displacing the medial rectus inferiorly and the optic nerve inferolaterally, suggesting of schwannoma. Similar lesion was noted in the left submandibular region. Treatment, left eye transconjunctival orbitotomy was done. Here first picture shows the orbital schwannoma specimen, and right specimen shows the medial rectus. And HP report of the orbital mass.
Wrap up quickly.
Orbital mass, it was consistent with the extensive degenerative changes with ectatic vessels suggestive of schwannoma and medial rectus mesenchymal hematoma. It's a post-op day 1 picture of the patient, and patient is waiting for squint surgery. My references. Thank you.
So when you say differential diagnosis, why did you say carcinoma as the first differential diagnosis? She's only 16 years old, right?
Yes, ma'am.
So what else can it be? Causes for proptosis in 16-year-old.
Ma'am, it can be hemangiomas in the children age group people, because of on examination there was no on retropulsion test was positive, so we cannot take into consideration of hemangioma and orbital cellulitis. Because patient did not present with a pain, redness, and periorbital inflammation, fever, we can rule out orbital cellulitis. And craniosynostosis, but there was no deformity seen in the cranium or in the facial symmetry.
Okay.
And rhabdomyosarcoma we can also consider, because it presents in the age group of like 7, those age group people, we can rule out that also. And yes, ma'am.
The previous diagnosis, they're saying that you sent that again for histopathology, or what?
Yes,
they sent? You sent repeat histopathology.
Yes, ma'am. LV, when they have done orbital decompression surgery, that was specimen was sent, and they showed it was a orbital schwannoma. Now she's complaining with same complaints, and left eye transconjunctival orbitotomy was done, and again the specimen was sent here.
Okay. So what would have happened in the first surgery?
Ma'am, like complete removal of the tumor was not done, ma'am. So there was a recurrence of the tumor again now.
These are well-defined tumors or not so well-defined?
Well-defined tumors, ma'am. No. But if the resection is not complete, then there is chances of recurrence.
Okay, fine. Okay, thank you.
Thank you.
Okay. Now, thank you so much, Dr. Vidyashri. Now we go on to our next participant, Dr. Anjana, whose topic is BKH, mentor Dr. Shilpa YD, also from Minto Eye Hospital. Please start your presentation. Please wrap up in 5 minutes. You have 5 minutes.
Yes, ma'am. Is my screen visible, ma'am?
Yes.
Yes. Very good morning to all respected teachers here. I am Dr. Anjana, myself Dr. Anjana, and I am from Minto Ophthalmic Hospital. My mentor is Dr. Shilpa Vaidi, and I'll be heading with my clinical case presentation. A 39-year-old female hailing from Bangalore, who is housewife, she presented to the Minto Ophthalmic Hospital OPD with the chief complaints of diminution of the vision, of both the eyes since 2 months. The patient was apparently normal 2 months back. Then she noticed diminution of the vision of both the eyes, which was insidious in onset and gradually progressive, and there was no history of associated pain or the redness of the eyes or the watering of the eyes, no history of glare or the colored halos, flashes or floaters, no history of usage of the spectacles, or no history of the frequent eye ache or the headache, no history of trauma to the eye, and no history of fever, rashes, malaise in the recent past. And the patient is not a known case of diabetes, hypertension, TB, asthma, the chronic kidney disease, or any associated cardiovascular diseases. Family and the personal history was nothing significant, and the general physical examination, she was a moderately built, nourished, conscious, cooperative, and well oriented to time place person, and systemic examination revealed within normal limit. And this is how
concentrate only on the positive points.
Yes, ma'am.
Only relevant negative.
Yes, ma'am. This is how the patient presented with the ocular finding in into our OPD, and she presented with a visual acuity of counting finger 2 meters both the eyes, with a near vision N12 in both the eyes, with a color vision being within normal limit both the eyes, and the best corrected visual acuity was not improving with the pinhole corrections, and the conjunctiva was normal in both the eyes, with the cornea showed the keratic precipitates in both the eyes, anterior chambers with the cells 1+, and the pupil was 3 mm sluggishly reactive in both the eyes, and the lens status was clear, and the anterior vitreous shows the 1+ vitreous cells. So this is the anterior segment picture showing the small pigmented keratic precipitates on the slit lamp examinations of both the eyes. The angle with the gonioscopy by 4 mirror Sussman gonio lens shows the open angle with the no neovascularization of the angle, and the distant direct ophthalmoscopy showed the dull glow because of the vitreous cells and the hazy media, and the indirect ophthalmoscopy with the 20D Oak lens shows hazy media with the blurred. Here the distant this is the indirect ophthalmoscopy with the 20D Oak lens. It shows the hyperemic disc with the blurred disc margins, with the cup disc ratio of 0.3, with the AV artery and the venous ratio of 2:3, with the fovea contour is altered, with the foveal reflex is dull, and it shows the multiple fluid filled pockets in the background retina. So this is the OCT picture of the patient showing the foveal contour is altered and the increased macular thickness in both the right and the left eye. The right is being 1410 microns in the right eye, with 1390 microns in the left eye at the foveal thickness, and it also showed the multiple the fluid filled packets with the subretinal fluid pockets, and also the subretinal septae formations, and this is the HD raster showing the subretinal septae formations with the subretinal fibrotic material depositions in both eyes. So this is the foveal contour is altered with the multiple subretinal fluid pockets with the subretinal septae and the fibrosis, with the serous detachments, and the macular thickness is being 1410 microns in the right and 1319 microns in the left eye. So this is the B-scan ultrasonography of the same patient showing the vitreous cavity shows the moderate to high reflective echo suggestive of the vitreous inflammation, and also the high internal reflectivity of the thickened choroid with the retinochoroidal thickness is being 2 mm, with the increased choroidal thickness suggestive of the choroiditis, and the axial length of both eyes show 23 mm. And the ONH and the globe contours appeared normal, and the mount-like elevations are also seen temporal to the disc suggestive of the serous detachments. And this is the fundus fluorescent angiography of the same patient showing the multiple hyperreflective the hyperfluorescent spots in the early phase, and also the subretinal pooling of the dye in the late phase was present. So with the summaries being the 39-year-old female middle-aged female patient presented to the OPD with the diminution of the vision being the counting finger 2 meters, and also the blurring of the near vision. blurring of the near vision. She presented with diminution of the vision in both the eyes. Yes, ma'am.
Please wrap up in 1 minute.
Ocular examination shows the counting finger 2 meters with the keratic precipitates present in the anterior segments with the 1 plus cells, anterior segments, and the vitreous cells were also 1 plus. And the fundus examination showed the hyperemic disc with the elevated disc margins and the hazy media with the multiple filled pockets suggestive of the vitritis as well as the papillitis. And the B-scan ultrasonography showed the multiple fluid-filled pockets suggestive of the vitritis, and also the high reflective inflammatory echoes suggestive of the vitritis, and the OCT and the increased choroidal thickness suggestive of the choroiditis. And the OCT images also showed the subretinal fluid pockets and the undulating RP defects with the septae and subretinal septae and the subretinal fibrosis present, which is more suggestive of the Oct disease. Thus, I come to a provisional diagnosis of the both eye Oct disease. In order to substantiate my provisional diagnosis, I would like to send certain investigations. The complete hemogram showed the WBC is being 11,600 cells, where the WBCs are slightly increased, suggestive of the infective foci, and the serology was negative. The ESR and CRP like acute phase reactants were within normal limit, and the RA factors, ANA, and the ANCA factors showed within normal limits. The Monto and the chest X-ray was within normal limit. The Monto test was negative, and since I'm suspecting the VKH, in order to rule out the associated the dermatological or the neurological or the ENT manifestations, I'd sent the ENT opinion showed the bilateral hearing sensitivity within the normal limits both the ears, and the dermatology opinion showed no evidence of the hair loss or the cutaneous manifestations, and neurology opinion showed MRI brain and the contrast showed no evidence of the acute infarcts or the hemorrhages or any space occupying lesions. And we started her on a high dose of the IVM intravenous methylprednisolone 1 gram for 3 days, followed by the oral corticosteroids tapered over according to her body weight, and we tapered over 3 to 6 months. And also the topical corticosteroids we added with the topical cycloplegics. And follow up after 3 months dose of the IVMP, the patient was symptomatically better, and the improvement of the best corrected visual acuity from counting finger 2 meter showed to 624 in both eyes. And also the indirect ophthalmoscopy showed the reduced subretinal fluid with the reduced serous detachments and the reduced panuveitis, and the OCT will also showed the reduction of the foveal thickness than before. So this is after 3 months of the follow up after 3 doses of the IVMP, where we can see the reduced foveal thickness, reduced foveal thickness to 336 and 449 of the right and the left eye after 3 months. And this is the reduced macular thickness at the fovea of 336 and 449 microns of both the right eye and the left eye. And the patient continued on the oral corticosteroids, and after 1 month we again followed up her, and the patient was symptomatically still better, and the improvement of the visual acuity from 624 to 66 of both the eyes. And indirect ophthalmoscopy showed the reduced subretinal fluids with the reduced serous detachments and also reduced panuveitis, and both the eyes the fundus was found to be normal, and the OCT of both the eyes patient showed to be normal within normal limits, with the final the macular thickness at the fovea was being 260 and 264 in both the eyes. Thank you, ma'am.
Thank you, Dr. Anjana. That was a nice presentation. I wanted to ask you, when you are talking about keratic precipitates, would you just say keratic precipitates in your slides? You just showed just keratic precipitates, but on your description you said some fine KPs. How ideally, how would you like to describe the KPs in any uveitis?
Ma'am, ideally the KPs we describe it on the size, ma'am, whether they are the small or the medium sized or the mutton fat KPs, or they are the small stillate KPs, or they are the old KPs. Here the patient presented with a small discrete and the small KPs in both the right eye and the left eye.
Okay, and would you like to also mention what is the distribution of the KPs, where they are located?
Yes, ma'am. Usually the KPs are the proteinaceous particle which are located over the corneal endothelium in a based on triangular pattern. They are called as the arts line in arts triangle. It's based on triangular pattern is basically because of the conventional current of the aqueous. Convection currents of the aqueous. Yes, ma'am.
Yeah. And would you also like to mention what is the flare cells alone? Is it enough in uveitis? What is the importance of mentioning about flare? What is the importance of grading the flare?
Ma'am, the flare is mainly because of the leakage of the proteinaceous particles into the vitreous, which will appears as a which appears as a moving dust particles because of the which gives the stimulate which mimics the Tyndall effect. Tyndall effect.
No, I got that. Okay, Dr. Anjana, that's fine. But what is the clinical significance of flare?
It is mainly because of it indicate the leakage of the protein particles from the leaking blood vessels, ma'am.
Okay, so basically you can also assess what is the severity of the uveitis, how is the patient response to therapy, and for long-term monitoring also flare grading of the flare is important, right?
Yes, ma'am. Yes, ma'am.
Dr. Rita.
Yeah, I would like to ask that you didn't mention, you said that you tapered off steroids.
Yes, ma'am.
In 5 days' time.
No, ma'am. I think she made it 3 months. I think she said 3.
Ma'am. Yes, ma'am. We initially we started her on a high dose of the intravenous methylprednisolone steroids for 3 days, followed by the oral steroids, ma'am. Since the VKH is a condition which requires the corticosteroid therapy for the prolonged duration, so it may require in 2/3 of the patients it may require up to 6 months, ma'am. In this patient, we started her on IVMP for 3 days, followed by the oral steroids in a tapering dose. And after 3 months of the follow-up, she was still on the steroids. We observed the improvement in the visual acuity from counting finger 2 meters to 624, and still we continued her on the oral steroids. And after 1 month of the oral steroid of the continuation, again her visual acuity improved from 624 to 66.
Yeah, but I would, as you rightly mentioned, that it takes at least 6 months.
Yes,
because if you're going to taper off every 5 days, it's going to definitely relapse. So you need to give a very slow tapering for these type of patients.
Yes, ma'am.
And once entered the chronic, they might even not be responsive to steroids. You might have to give them immunosuppressants instead.
Yes, ma'am. If the patient is
giving them steroid,
if the patient is not responding to the corticosteroid, we may have to start her on the immunosuppressants like the infliximab or the cyclosporins or the tacrolimus, ma'am. After immuno.
Yeah. So for the optimum results, you're going to taper off very slowly, and instead of 5 days, you might give them for 1 dose for up to 10 to 15 days, and taper off over a period of 6 months.
Yes, ma'am. Sure, ma'am.
And Anjana, I also
and what are the systemic associations? Yeah.
No.
Yes, ma'am.
I would like to ask, what are your expectations of systemic associations when you see a suspected VKH patient?
Yes, ma'am. So, VKH is a idiopathic autoimmune with a multi-system involvement, especially affecting the melanin-containing tissues, especially the ear, the meninges, and the eyes, and also the melanin of the skin. Therefore, the neurological symptoms like the meningitis, encephalopathy, or the multiple cranial nerve involvement, if it is associated, we have to look for, ma'am. And also in the ear, the inner hair cells affect can lead to the sensorineural hearing loss, tinnitus, and the vertigo components. And also the dermatologically, like the skin involvement can result in the vitiligo, hair loss, or the alopecia. And also the system, more commonly the panuveitis condition is associated with the other systemic involvement in conditions such as the ankylosing spondylitis, if it is associated with the HLA-B27 association, where there will be lower backache with the involving the sacroiliac joint and the anterior uveitis, and also the Ritter syndromes, where there will be the associations of the uveitis with the urethritis, and also the juvenile
we
idiopathic
won't
arthritis.
Yeah, we won't deviate from the basic PKH. So
Yes.
what I meant to say that you look for poliosis, alopecia. So you have to highlight whatever you're saying, because
Yes.
these are very common things that we must rule out. And
Yes.
you must mention, rather than saying more of the negative things, please focus more on what positive findings you saw and you found them negative.
Yes, ma'am. Sure.
Yeah, otherwise your case presentation is good.
Yes, ma'am.
Dr. Soma.
Yeah, no, it's just a quick thing. So when you're seeing a patient with bilateral, so broadly this is a bilateral pan-uveitis, right? What are
Yes.
the other disease entities that you'll, okay, so this is clearly a VKH, but before you reach that diagnosis, what are the other broad categories of, etiologies that you would want to rule out, like, let's say, infection? I mean, so what are you looking at? So what are the other things?
So before coming to my provisional diagnosis, I just want to rule out, have some differential diagnosis in my mind, ma'am. First, I'll rule out the sympathetic ophthalmitis that also presents with the panuveitis, but it is typically the
Okay, sorry.
yes, ma'am. But there is a typically associated history of the penetrating trauma to the eye will be there. Since the patient is not having ear, I just did that ruled out that, and also the posterior scleritis. The posterior scleritis usually present in the middle-aged woman with a bilateral panuveitis, but it can be differentiated on the B scan ultrasonography, which shows the high intensity of the thickened sclera with the scleral thickening is being highlighted, and also with the retrobulbar edema can be seen in case of the posterior uveitis, and the typical T signs can be ruled out. Hence, I ruled out the posterior scleritis, and also the sarcoidosis, ma'am. Sarcoidosis also presents with a bilateral panuveitis, but the typical fundal findings like the candle wax dripping or the snowball opacities will be there. Since the patient was not having those, and the chest x-ray and the chest x-ray was within normal limit, which in the sarcoidosis typically we shows the bilateral hilar lymphadenopathy, since it's typically affects the lungs and the lymph node involvement. And also the patient was not presented with a cough, breathlessness, which will be a typical features in case of the sarcoidosis. Thus I ruled out the sarcoidosis. And one more thing, the acute multifocal, the polypoidal, the flacoid epitheliopathy, which will be the flacoid appearance of the fundus, which will be typical in case of the flacoid maculopathy. That I ruled out. Hence, with all this, I come to the provisional diagnosis of the Vox-Koyanagi-Haradas disease, ma'am.
Will you also consider some malignancies, like some?
Yes, ma'am. Primary intraocular malignancies that can be ruled out with a lumbar puncture. Showing the CSF analysis will shows the lymphocytic pleocytosis, especially in case of the VKH, ma'am. Thus we can rule out with lumbar puncture.
Macrophages with
macrophages laden melanin laden macrophages can be seen, ma'am.
Thank you.
Thank you.
Judges,
Thank you.
Dr. Rita and Dr. Suma. Thank you, Dr. Anjana, for
Yes,
a wonderful case presentation.
Yeah.
We were going over now to invite Dr. Umme Kulsum.
Thank you so much.
Dr. Kulsum, please start sharing your slides. The mentor is Dr. Shilpa. A very gentle request to the participants that please do not exceed beyond 5 minutes. Please do not exceed beyond 5 minutes. And request to the judges also that the discussion time allotted is 5 minutes. So please ask the most relevant questions, and because there is a long queue of participants waiting, I also request everybody to please get your lunch and let's have a working lunch. Okay. So yes, over to Dr. Umme Kulsum.
Good morning, everyone. Can you hear me?
Yes.
We can hear you, Dr. Umme. Yes.
I'm Dr. Umme Kulsum from Minto Ophthalmic Hospital. I'll be presenting a clinical case presentation on intravitreal cysticercosis with inflammatory retinal detachment. And my mentor is Dr. Shilpa Vaidi from Minto Ophthalmic Hospital. Here is a patient, 27-year-old Mr. Rajesh, hailing from Uttar Pradesh, who's a gardener by occupation. He came with the complaints of diminution of vision in left eye since 8 months, which was insidious in onset and gradually progressive. It was associated with history of redness, pain, and headache occasionally, which subsided spontaneously. He also gives a history of eating pork in the past. There was no history of diplopia, ptosis, proptosis, flashes, or floaters. There was no history of seizures or any other skin lesions, nausea, vomiting, diarrhea. No history of any ocular trauma or any previous ocular surgery. Past history, no history of similar illness in the past, and no history of any other systemic illnesses. No history of similar complaints in the family. He had a good diet with sound sleep, and his appetite and bowel and bladder habits were regular and normal. Summary, a 27-year-old male with history of pork consumption in the past presented with diminution of vision in left eye since 8 months. It was associated with history of redness, pain, and headache occasionally, which subsided spontaneously or on use of any medication. General physical examination. Patient is a young male, moderately built and well oriented to time, place, and person. His vitals were normal. Systemic examination, respiratory system, central nervous system, cardiovascular system, per abdominal examination was normal. Coming to ocular examination, head posture was normal, ocular posture was orthotropic, forehead and eyebrows were normal and at the same level on both sides. Facial symmetry, symmetrical and normal. Visual acuity, patient had a visual acuity of 6/6 in right eye and counting fingers at 2 meters in left eye, which showed no improvement on pinhole correction. His best corrected visual acuity was counting finger at 2 meter. On refraction, there was a dull glow in left eye. Projection of rays was accurate in both eyes. His upper eyelids, palpebral were normal in position, movements, lid margins, eyelashes, and skin of eyelids were normal in both eyes. Palpebral aperture, vertical palpebral aperture was 9 mm in both eye, and horizontal palpebral aperture was 28 millimeter. Lacrimal apparatus was normal. Conjunctiva showed mild congestion in the left eye in palpebral and bulbar conjunctiva. Sclera was normal. Cornea was normal in size, shape, surface, and stroma in both eye. Sensations were intact in all quadrants in both eye. Anterior chamber depth was normal. Normal depth with Van Herrick's grade 3. Cells, 2+ cells were seen in the left eye. Iris was normal in color pattern. Pupillary reactions were normal. 3 mm regular round reactive to light pupil was seen in both eye. Intraocular pressure was measured at 2:30 p.m. 12 mm Hg in right eye and left eye 16 mm Hg. Lens position, shape, transparency were normal. Extraocular movements were full range. On distant direct ophthalmoscopy, a red glow was seen in right eye and a dull glow was seen in left eye. Fundus examined by indirect ophthalmoscopy using Oct 20D lens. Right eye was, the media was clear. Disc normal in size, shape, color with well-defined margins with healthy neuroretinal rim. Cup disc ratio was 0.3. Vessels were normal. Foveal reflex was present and background was normal in the right eye. Media was clear in left eye. Disc was normal in size, shape, color with well-defined margins with healthy neuroretinal rim. Cup disc ratio was 0.3. Vessels normal, AV ratio 2:3. Macula was off. In the background, a live translucent white cyst with dense white spot formed by the invaginated scolex with typical undulated movements noted intravitreally with a grayish area in the inferior quadrant suggestive of retinal detachment was noted. This is the fundus picture of the left eye, where a live translucent white cyst with a dense white spot was noted. Inferior retinal detachment also was noted. On B scan, multiple dot-like echo of low reflectivity suggestive of vitritis was seen. Membranous-like echoes of high reflectivity with limited after movement persisting on low gain suggestive of retinal detachment with macula off was noted. Hypoechoic cyst with a hyperechoic scolex was seen. MRI brain was done to rule out any neurological involvement. It's showed a small, well-defined ring enhancing lesion with associated intralesional T2 weighted hypointense speck of approximate size of 5 into 4 mm noted involving the right cerebellar hemisphere. There was a query retinal thickening with associated irregularity noted involving the left lobe with few associated tiny nodular areas, suggestive of sequelae to granulomatous etiology, that is neurocysticercosis. Right eye within normal limits. The diagnosis in the left eye was intravitreal cysticercosis with inflammatory detachment, retinal detachment. Management, health education regarding improvement of sanitary conditions and hygienic consumption of food is necessary for prevention of disease and for prevention and disease control. Systemic cysticercosis should be always ruled out. MRI and neurologic consultation to look for neurocysticercosis, systemic steroids pre and post surgical removal of the intravitreal cyst, surgical removal of intravitreal cyst either by transretinal or transscleral route, microincision vitrectomy surgery, that is the surgical removal of the cyst using the vitreous cutter is advocated these days, membrane peeling and silicone oil implantation to manage retinal detachment. In microincision vitrectomy surgery, here in our hospital, this was used. Removal of the cyst using the vitreous cutter is advocated. The high-speed cutting rates with the maximum suction ensures that the cyst contents barely come in contact with the ocular structures with minimum release of toxins. In our case, cyst was removed using a high-speed vitrectomy cutter. Systemic corticosteroids were used before and after surgical removal of the cysticercosis. Removal of the cyst to avoid inflammation. Thank you.
So she was on time. She finished on time. I think that was really good.
Yes, thank you.
So Dr. Umi, I wanted to ask, how did you manage the RD?
Ma'am, membrane peeling was done and silicone oil implantation was done following cyst removal using the vitrectomy cutter.
And what was the post-op visual acuity?
Ma'am, post-op visual acuity, the patient had counting finger at 1 meter, and later we lost him to follow-up as he wanted to follow up in his hometown, that is Uttar Pradesh.
And what about the neurocysticercosis? There was some lesion in the cerebellum.
There was one lesion. On neurology consultation, they advised for observation and management since it was a very small lesion and the patient did not have any other neurological features like seizures or any other CNS manifestations.
Okay.
So what else could be, the Dr. Umi, what else could be in the differential diagnosis of the cyst?
Ma'am, any any other parasitic infections like toxoplasmosis also can be considered.
Does it appear like a cyst?
Sorry, ma'am?
Does it appear like a cyst, toxoplasmosis?
Yes. No, it does not appear like a cyst. Any other tumors also can be considered.
Well, they could be in literature. They do have hydatid cyst or hematomyositis.
Okay.
Which could be considered. And then what, you didn't show any investigations that were considered.
Ma'am, a stool examination was sent, ELISA was considered, but the patient was not affordable. So he had come with these reports, MRI, brain and other blood investigations, which were normal. So he was taken up for surgery following all neurology review and physician review.
Is there any long-term sequelae of having this cyst in retina? Vitreous and retina. Is there any long-term sequelae?
Ma'am, I'm not sure.
Okay, I think it's the follow-up because the patient was asked to follow, so it's very difficult but
Yes.
we need to follow up the patient
Yes, ma'am.
to see the.
Dr. Ume, I had a question for you. You said
Yes, ma'am.
Mr. Rajesh, positive history that he was eating pork.
Yes, ma'am.
Suppose if you did not have that history, if Mr. Rajesh said that he did not eat pork, or for that matter, he was vegetarian, would you consider the diagnosis of cysticercosis?
Yes, ma'am.
You would?
Food can be this can be contaminated with any other food. Food contaminated with sodium eggs. So, since he was also gardener by profession, we can consider it.
Yeah, that was a very important thing, which you could have mentioned also, that you would have done that. There's a very famous tennis player, Leander Paes, who had cysticercosis of the brain, and he's a vegetarian.
Yes, ma'am.
So you remember he had to halt his tennis career and get the surgery done and then resume.
Yes,
So always remember that eating pork is not the only history which clinches a diagnosis. You can consider cysticercosis even if a person is vegetarian. So thank you, Dr. Umme, and thank you, the judges, Dr. Rita and Dr. Suma. Please be there because the next case is also of retina, a traumatic choroidal rupture. And Dr. Akhila Matthew is now ready with her slides, and we are happy. We thank Dr. Shilpa, who was the mentor for the last two cases. Dr. Hemlata is the mentor for Dr. Akhila. Glad that Dr. Hemlata is here, and Dr. Akhila, kindly share your slides.
Good morning, everyone.
Good morning. Good morning. We can see your slides. We can hear you. Please start.
So I am Dr. Akila from Minto Ophthalmic Hospital, and first of all I thank to WS and Dr. Hemalata, my mentor. And coming on to my case report, a patient, Prasanna, 32-year-old male, residing from Mysore, presented to our OPD with complaint of diminished vision in the left eye since 1 month. So we went on to a detailed history taking. The patient had a diminution of vision in the left eye since 1 month, which was insidious onset, progressive nature, and painless. And there was no history of floater splashes or no history of redness, watering, and itching. So on detailed past history, patient gives a history of road traffic accident on 28/6/2020 while driving a two-wheeler, after which he sustained injury to the right side of the head and eyes and right shoulder, for which he had undergone evisceration of the right eye on the next day of injury under general anesthesia, and clavicular fracture repair was also done in 1 week of the injury. So coming on to the positive history, there was no systemic illness, and the general physical examination revealed normal vitals and normal systemic examination. So coming on to the ocular examination, the facial there was a facial asymmetry because of the right eye evisceration. Head posture was normal. The visual acuity was 624, which was improving to 618 with pinhole in the left eye. So on coming to the slit lamp biomicroscopic examination, revealed a normal anterior segment evaluation with normal lids, conjunctiva, cornea. Anterior segment was quiet and the pupil was 3 mm, reactive to light with clear lens. So this is the slit lamp biomicroscopic picture of the patient. And next, coming on to the fundus examination, dilated funduscopy with 90D indirect ophthalmoscopy showed a clear media. And there was if I show you the dilated fundoscopy image, there was a white yellow curvilinear. First of all, there was a clear media and the disc appeared normal with a normal cup disc ratio of 0.3, and the macula foveal reflex was still, and I could find a white yellow crescentric curvilinear lesion superior to the fovea and superior to the macula, and there was a grayish elevated lesions at the macula. So this is my positive finding in the fundus and the fundus picture of the patient of the left eye. So again, and based on the history of trauma and my 90D fundoscopic examination, I came to a concluded to a provisional diagnosis of traumatic choroidal rupture, which is complicated by a secondary choroidal neovascular membrane. So to confirm my provisional diagnosis, I came to the investigations. First, we went on to do an optical coherence tomography study of the left eye, which showed this image. You can see there is a subretinal hyperreflective material at the site of previous choroidal rupture. So this is an HD raster image of the left eye. So we went on to OCT angiography, which is a non-invasive quick procedure to evaluate for any neovascularization, and I could find possible new vessels, neovasculars in the juxtafoveal area in the site of all choroidal rupture. Then we went on to a confirmatory test of diagnostic test of fundus fluorescent angiography, and we could find hyperreflective echoes like on the peripheral juxtafoveal areas at the site of choroidal rupture. And so okay, so we have planned for a intravascular injection, intravitreal injection of anti-VEGF for this patient, and we have given intravitreal ranibizumab 0.5 mg and 0.05 ml for this patient, and we have followed up the patient on post-op day 7, and post-op day 7 we have repeated the OCT of the patient, and we could find a reduce in thickness of the neovascular lesion, and this is a post-op day 14 image showing further decrease in thickness of the neovascular membrane. So we have followed up the visual acuity of the patient simultaneously, and on post-op day 7, the patient presented to us with a visual acuity of 624 improving to 618. So on post-op day 7 of the procedure, we could find a visual acuity of 612 improving to 69, and post-op day 30 again we have re-evaluated the visual acuity. It was 69 in the left eye, and further we have lost the patient to follow up. So this concludes my case. Thank you.
Thank you, Dr. Akila. One doubt I had was, when did you see this patient? How long post the injury, post the RTA, did you see this patient?
Patient had injury in 28/6/2020, and patient
Correct.
had come to us on month of December in the same year.
Okay. And from whatever history you've written, so the injury was to the right side of the face and the right eye,
Yeah, ma'am.
but you are assuming that there was a blunt trauma to the left eye, is
Yes,
it?
ma'am. Yes, ma'am.
Okay. And just go to your examination findings. What was the intraocular pressure?
Ma'am, intraocular pressure, which I haven't recorded here or mentioned here, but we have done a complete workup before the complete evaluation, and intraocular pressure was normal.
Okay. And is there something else, some other examination that you have missed when there is a case of, let's say you're looking at an old blunt trauma, and so what should you be looking for? One more examination, which like
keeping in mind, yes, ma'am. Keeping in mind differential diagnosis of sympathetic ophthalmitis, we have to rule out any raised intraocular pressure and gonioscopy. Actually, ma'am, I haven't included the details, but we have done a complete glaucoma evaluation also in this patient with normal. No, there was no evidence of glaucoma with normal findings.
Okay, what exactly would you be looking for when you do the gonioscopy for such a patient, blunt trauma? What will you be looking for in the gonioscopy?
Angle recession, secondary to trauma.
Okay. And on the OCT image, there was no subretinal fluid or any, there was no...
Yes, ma'am. On the fundoscopy examination also, we could just see a grayish elevator lesion. And so we, on the OCT image also, we couldn't find any subretinal bleed or exudate. But the image was suggestive of a classic CNVM picture with the lesion encroaching above the RP layer and hyperreflective nature.
Okay. Ma'am, you're muted. You're muted. Dr. Rita,
So
you're
when
muted.
you say
Hello?
is it better now?
Yes, ma'am.
Yeah. Dr. Akila?
Yes,
Yeah,
ma'am.
when you say it's classic, you thought it's a classic CNVM. Did you find correlated FFA in that? Because FFA doesn't show any leakage.
Yes, ma'am. Actually, my FFA image, the image is not very good quality, but in the image, I have found few juxtafoveal hyperreflective area. There is hyporeflective area in the center, but juxtafoveally few hyperreflective areas I could find.
Then in that case, I would still consider Occult to be more appropriate rather than the classic CNVM. And any of the treatment, of course, would be the same.
Yes, ma'am.
I would like to add a point here, ma'am. Like this patient, late phase, she has not got the picture. The size of the the size of the lesion also and intensity of dye increase progressively. And these cases, there will be breach in the Brooks membrane. So most of these cases will go for type 2 CNVMs, ma'am. That is classic.
That's right.
Okay. Now we'll go on to the next presenter.
Thank you, ma'am.
Thank you.
Dr. Nikita Sankori. The topic is the influence of spectral domain anterior segment OCT in the management of mycotic keratitis. Requesting Dr. Samia to be judging this. And the mentor is Dr. Sunil Biradar. Nikita is from BM Patil Medical College and Hospital, Bijapur. Dr. Nikita, are you there?
Oh, yes, ma'am.
Yes.
Good morning, ma'am.
Good morning. Please stick to time, 5 minutes.
Good morning, everyone. I'll be presenting a paper on the influence of spectral domain anterior segment optical coherence tomography in the management of mycotic keratitis. My mentor is Dr. Sunil Biradar. So it's an original article. There's no conflict of interest or financial disclosure. These are the outlines of my presentation. So fungal keratitis is a severe disease in which diagnosis can be challenging. It is particularly common in tropical areas like India, where the incidence is 44% to 47% because of its large agrarian population. Fungal keratitis leads to serious complications like endophthalmitis, perforation, and blindness. Introduction of anterior segment optical coherence tomography scan makes objective assessment and monitoring of keratitis easier. It is a contact and non-invasive imaging modality, and it provides cross-sectional imaging of cornea. This region of North Karnataka being predominantly agriculture population area, risk of corneal injury is high, and so is the risk of fungal keratitis. Slit lamp biomicroscopy is a gold standard method for monitoring corneal infection, but it is very subjective. So little is known about the application of anterior segment optical coherence tomography in fungal keratitis. Therefore, this study is a small step for better management of fungal keratitis. The aim of the study is to evaluate the influence of spectral domain anterior segment optical coherence tomography in the management of fungal keratitis. The objective is to evaluate the corneal thickness and infiltrate thickness using ASOCT. It's a prospective observational study done during December 2020 to 2021 in the Sri B.M. Patil Medical College Hospital and Research Center. Sample size was 25 and the written informed consent was taken. Inclusion criteria included smear positive and culture positive fungal corneal ulcer presenting to outpatient and inpatient department. The exclusion criteria involved all cases of fungal corneal ulcer, except them were all excluded. Examination and scanning protocol, a detailed history was taken, slit lamp examination was done at each visit, baseline clinical photography with and without fluorescence staining was performed, B scan was performed to rule out endophthalmitis.
corneal scraping was performed in all patients and was subjected to gram staining, 10% KOH mount, bacterial culture, and fungal culture. Anterior segment optical coherence tomography scan were taken at the center of the infiltrate using 5 mm horizontal rasters was performed at day 0, 7, 14, 21, and 30. And standardized scanning protocol was used in all cases. Mean values of the following parameters were calculated at each visit and was compared with the baseline. So the parameters involved corneal thickness, which was measured at the center of the infiltration with 1 caliper arm on the anterior most hyperreflective corneal surface and the second arm on the hyperreflective endothelium. Infiltrate thickness was measured in the center of the infiltration with 1 caliper arm on the anterior most reflective hyperreflective corneal surface and second arm on the posterior border of the reflective area. Infiltrate thickness, infiltrate width was also measured on the corneal surface. Any values less than 0.01 was considered statistically significant. In this study, in our study, males presented with fungal keratitis more commonly than females, and they were mostly presented with between the age of 50 to 60 years. And among the 25 sample size, 16 were culture positive and 9 were smear positive. Among the culture positive, 10 were positive for aspergillus and 6 were for fusarium. So in the results, when we saw the corneal thickness, the baseline value was 650 plus or minus 108, which gradually reduced from day 14. And coming to infiltrate thickness, the baseline was 401 plus or minus 91, which gradually decreased from day 21 onwards. Now, corneal thickness among the fungal keratitis, when we measured, fusarium showed baseline low corneal thickness, which was 624 plus or minus 125, which rapidly worsened over 1 month, and 3 out of 6 patients presented with perforation. Whereas in aspergillus, the corneal thickness was 645 plus or minus 109, which gradually worsened, and 1 out of 10 patients presented with perforation. Discussion. According to Gopinathan et al., slit lamp biomicroscopy is the gold standard method for monitoring corneal infection, but they found that certain details like infiltrate depth and stromal thickness was hard to analyze during corneal edema, which can be easily examined using ASOCT. Now, according to Chirambo et al., time domain ASOCT had advantage of larger field of view and longer wavelength, but using SD-OCT in our study, we found that SD-ASOCT had better resolution and better delineation. Constantinopoulos in his study found that he did a study on bacterial keratitis, where he found that there was rapid decrease in the corneal thickness and infiltrate thickness in early phase, that is from day 0 to day 3, and in late phase, that is from day 7 to day 14, and infiltrate thickness reduced faster than corneal thickness. In our study, we found that corneal thickness decreased more rapidly in cases that perforated, especially in the first week among fungal keratitis secondary to fusarium, and there was decrease in corneal thickness was significantly slower in patients with aspergillus. Now, according to Namrata et al., yeast had rapid progression to perforation, but in this study, we found that fusarium species had decreased corneal thickness at presentation, which worsened over 1 month, with 3 cases ending up in perforation. Therefore, it can be used to monitor the progression of the disease. These are the limitations of the study. In conclusion, SD-ASOCT can be used as an adjunctive tool for objective assessment and quantitative monitoring of patients with fungal keratitis with greater accuracy. The novelty of the study is little is known about the application of ASOCT in fungal keratitis. So this study dives into make a use of this procedure for better monitoring and follow-up of these patients. And it can be used as an adjunct in the management of fungal keratitis. These are my references. Thank you.
Well, very good presentation. It's a novel idea to use the anterior segment OCT for knowing the progression of the ulcer. Well, my question to you is, what is the end point of the study?
At the end point, we could analyze the corneal thickness, which was significantly reduced in fusarium species at presentation itself, which rapidly progressed over 1 month. And we
progressed
could,
meaning?
worsened over 1 month. There was rapid decrease in worsened over 1 month. And at the end of the month, 3 patients presented with perforation. So we can use this modality to monitor the progression of the disease. When compared to aspergillus, there was a gradual worsening of the corneal thickness.
Okay, and now for the progression, when you are monitoring progression, you are also able to see it on slit lamp, right?
Yes, ma'am. But slit lamp in cases of corneal edema, it is hard to measure the corneal thickness as well as the infiltrative thickness also is difficult to monitor using slit lamp.
Okay, so you're able to actually make out which one is the infiltrate and which is the edema.
Yes, ma'am. Infiltrate thickness. Yes, ma'am.
You can delineate that.
Even in the presence of edema, we can measure the infiltrate thickness, ma'am.
When you are measuring the infiltrate thickness, isn't it a subjective measurement? Because it depends on where you put the starting point and the means to gauge the extent of the infiltrate.
Ma'am, in our study, what we did was at presentation, we focused on the highest point of infiltration and we used the same spot during the follow-up so that we could measure it.
How were you able to understand which is the exact same spot?
Ma'am, highest point of corneal infiltrate thickness we used, ma'am, at presentation, and we used the same in following the.
Yeah, so how do you know that it is the same point that you are checking at on follow-up?
Ma'am, we refer to the previous follow-up images and we could analyze where it was.
All right, okay.
Doctor, I have a question here. Good presentation, a nice case series presentation. Slit lamp examination is done almost every day. In case of fungal keratitis, probably the patients are admitted also. How often were you doing a ASOCT?
Ma'am, we did ASOCT on day 0, day 7, 14, 20, 21 and 30.
Irrespective of the progression, see, all patients might not respond the same way.
Yes, ma'am. That was the limitation of the study.
Okay. Okay. Anything else that you noted?
Ma'am,
I'm sorry, ma'am. Anything else that you noted? Was any intrastromal voriconazole given?
Ma'am, no, ma'am. We started on topical antifungals, and we monitored.
Topical antifungals, which two? Only Natamet or even voriconazole?
Voriconazole also was given.
Oral voricanazoles?
Oral itraconazole was started.
Itraconazole was started, and were they classified based on that? Patients who received oral itraconazole and patients who received only topical medications?
Ma'am, we didn't compare the treatment aspect in this situation. We only measured the corneal thickness and the infiltrative. We didn't use that factor in this study, ma'am.
Okay, so no intrastromal injections or AC tabs, nothing was done. No secondary glaucomas were encountered on your study when you were seeing the ASOCT?
Ma'am, secondary glaucomas were encountered, ma'am, but we didn't use that as a parameter in the study, ma'am.
Okay. Oh, you're talking about only the case series. Okay.
Yeah.
Okay. Any descemetocele noted?
Descemetocele, actually, since we did the ASOCT during the particular dates,
exactly.
we missed that.
Yeah, I think that is one of the major thing that unlike the slit lamp examination, this is done on few days, I mean, day one, on some prescribed dates. So probably if there's a progression rapidly earlier than that, we don't know. Probably that is one of the limitations.
Yes.
Yeah.
All right. Thank you so much. Now we go to the next presenter, Dr. Sakshi Ramnani, who is talking on a case of idiopathic polypoidal choroidal vasculopathy. Mentor is Dr. Soumya from JSS Medical College.
Good afternoon, everyone. And thank you to Women Ophthalmic Society for giving me this opportunity. My case is boomerang of fluids in IPCV, what goes around comes around. A 61-year-old female from Mysore presented with diminution of vision in right eye since 15 days. The diminution of vision was insidious in onset, gradually progressive, painless. There were no similar complaints in the past, no history of previous ocular surgery or trauma. She gives no history of diabetes or hypertension, and there's no significant drug history.
Dr. Sakshi, sorry to interrupt, but the slides are not moving.
Okay. Is this okay, ma'am?
Yeah.
Yeah.
Okay. On ocular examination, her uncorrected visual acuity in the right eye was 636, improving to 618. Left eye vision was 66. Anterior segment examination in both eyes was normal. On fundoscopy in the right eye, the disc was normal with a cup disc ratio of 0.3. Vessels were normal and the macula showed a large serous pigment epithelial detachment with normal peripheries. The left eye fundus was normal as seen. OCT macula right eye showed a dome-shaped serous pigment epithelial detachment with pockets of subretinal fluid. The ICGA right eye showed peripapillary polyps and large serous pigment epithelial detachment. OCT macula and ICGA left eye were normal. She was diagnosed as idiopathic polypoidal choroidal vasculopathy in right eye based on the OCT macula and ICGA findings. We had planned her for serial intravitreal injections of aflibercept. Physician clearance was obtained, informed consent was taken, and patient was followed up regularly with OCT macula on each visit. She underwent the first dose of aflibercept in September 2021, after which her uncorrected visual acuity was 612. OCT showed a decreased PED height with minimal SRF. The second dose was given in October, visual acuity 6.9. The subretinal fluid was resolving and the PED height was decreasing further. The third dose was given in November 2021, after which the visual acuity was 6.9 and sub-RP fluid was almost resolved. In January 2022, when she visited us, her visual acuity was 6/9. The fundus showed subretinal lipid deposits, and the OCT showed an almost normal foveal contour with almost minimal subretinal fluid. So we advised her for treat and extend regimen and asked her to review after 4 weeks. So that's the beauty of science. Things don't always go as planned. She presented again within 3 weeks in January with diminution of vision and metamorphopsia. Her uncorrected visual acuity was 624, improving to 612, and OCT showed a recurrence of PED and subretinal fluid. She was given the 4th dose of aflibercept in February 2022, and at 1 month post-injection, she showed no improvement. The visual acuity declined to counting fingers at 1 meter. Fundus examination was showing a tall PED with heme accumulation. OCT was showing the same PED with some SRF. So polypoidal choroidal vasculopathy is a disease of choroidal vasculature prevalent in middle-aged women. The prevalence rate is 4 to 9.8%. And symptomatic patients with PCV can have complete regression without severe vision loss with photodynamic therapy and anti-VEGF treatment. Patients can present with blurred vision, central or paracentral scotoma, and dim vision in the affected eye. Fundus examinations show orange reddish bulb-like lesions budding from the choroid into the subretinal space and can be associated with recurrent significant hemorrhagic exudative detachments. The clinical diagnosis is a constellation of ICGA, FFA, along with OCT. I'd like to discuss the causes for recurrence and the non-responsiveness to aflibercept injections. The reported rates of PCV eye resistance to intravitreal anti-GF agents was 14.3%. And studies that showed tachyphylaxis and non-responsiveness to repeated intravitreal aflibercept injections were seen in lesions beneath the retinal pigment epithelium with no intraretinal edema, serous PED at the baseline, type 1 CNV, fibrovascular PED, and higher chronicity of ARMDs. Failure of proper line of cold storage could be another cause. The causes for recurrence of the disease may be because of some subclinical activity that is preceding the CNV activity, or it could show remnant polyps despite the dry macula after aflibercept treatment. There were studies comparing the baseline length measurement of the PD in OCT, and the PDs with apical base length, the shorter lengths, showed more recurrence compared to longer PED base lengths. So we planned her for further management. We've asked her to repeat FFA and ICG to look for recurrence or presence of any subclinical polyps. And the plan of management could be that we could either continue with the 5th dose of the aflibercept or change over the anti-VEGF to ranibizumab or brolucizumab. Photodynamic therapy was also considered but debated because of the subfoveal location of the PED. These are my references. Thank you.
Thank you. So my question was: Is this a characteristic OCT picture of the PED? What you would expect in a PCV?
Yes, ma'am. It was a very classical tall PED with subretinal fluid.
Okay, but what do you expect? What is the classical picture of a PED in a PCV? What are the signs that you look for? What are the things that you look for?
Maybe scarring, polyps.
No, I'm talking about the PED. What is classical? Notch PED, thumb-like PED. That's what I'm talking about. The OCT picture and the double layer sign.
Yes, ma'am.
Okay, and so would you, these polyps you said were peripapillary. Unfortunately, you've not shown us the ICG image, so we don't know where is.
Unfortunately, I don't have the ICG image.
Correct.
But,
so I didn't understand why we couldn't consider PDT at the first shot itself, because this is a peripapillary polyp, right? So
yes,
because in your last slide you said that you didn't consider PDT because the PED was subfoveal. So
yes,
that kind of didn't make sense. I mean, it's another fact that the patient might not have been able to afford the PDT, and that's why we didn't do the PDT.
Yes, ma'am. Actually, initially only we had counseled her for aflibercept, and since she was responding to the first 3 doses of aflibercept, PDT was not considered.
Okay. Okay. And when you're repeating the ICGA, what will you be looking for? What will you be looking for in the ICGA?
Ma'am, we'll be looking for any subclinical polyps that are still causing this recurrence.
So after the injections, you'll be looking for some resolution of the polyp. And what about that abnormal vascular network? Will you have to look for any exudation or any changes in that?
Yes, ma'am. Yes, ma'am.
Okay.
Well, it's very documented that large polyps and stronger BVN will lead to recurrent leakage of fluid. So as I think the voice was not clear right now. So what I understand, Dr. Sma already said that the polyps being peripapillary, the PDT should be considered at that location rather than at fovea.
Yes, ma'am. We can. Yes, ma'am. We've actually called her for follow-up. We've counseled her for brolucizumab also, and we will be counseling her about PDT.
I think she because in certain cases, rather than tachyphylaxis, there are certain cases which respond only when you laser the polyps.
Okay, yes, ma'am.
And the PDT, even if it's subfoveal, then we can use low fluence PDT even in the subfoveal polyps.
Yes, ma'am. Yes, ma'am.
Yeah, so that it's the polyps that need to be lasered and the leakage needs to be stopped to reduce this recurrent accumulation of fluid over there.
Ma'am, the only non-responsiveness was because after the 3rd dose, her OCT was almost normal. Her visual complaints had all come down. The OCT was normal. She was very happy, satisfied, and we told her to come back after 4 weeks, but she presented within 3 weeks only, saying that she's seeing that blob and she's feeling that metamorphopsia. And then after the 4th dose also, she didn't it didn't come down again. So that's why we were thinking of non-responsiveness to aflibercept.
Right. It could be possible, but I think she is the right candidate which should be considered for PDT. Although I understand that PDT is available at very limited centers in India. I worked in Hong Kong and we've done studies on the CCV. We've done low fluence, we've done full fluence, and after lasering the polyps with PDT, the thermal laser, it actually helps a lot. So probably this is the right patient who should be considered for PDT.
Sure, I'll talk to her when she comes back for follow-up. Actually, she's not been coming for follow-up lately. She was very regular in the beginning.
All right. Thank you so much. We now,
because in my opinion, this policy may not be so effective.
We now move to our next presenter, Dr. Sumangala from KIMS Hubli. The topic is orbital mucormycosis, save your eye to save your life. The mentor is Dr. Lakshmi B.R. Dr. Mangala, are you there?
Hello, yes ma'am. Hello.
Yes.
A warm good afternoon, everyone. I'm myself Dr. Sumangala from KIMS Hubli. In the last year, that is in the second wave of COVID, we can see a rapid surge of orbital mucormycosis cases. So we have a patient, a 64-year-old male patient, Hanumantappa Yellappa, residing from Dharwad. He presented with to KIMS casualty with a COVID positive status with comorbidity associated with known case of diabetes mellitus since 9 years on oral hypoglycemic. Okay. The patient mainly complains of the pain on the right side of the facial swelling and a headache since 1 week and an orbital inability to open the eye in the right eye since 1 week. He gives a history of COVID positive history 15 days back and he was hospitalized for that. He was not on any oxygen independent and not received any steroids for that, and he was vaccinated for first dose of COVID vaccine. At the time of presentation, his oxygen saturation was 95% at a room air he was maintaining. Coming to ocular examination, his left eye was within normal limit. Coming to right eye, his vision was PL negative. There is a presence of lid edema, complete ptosis, severe chemosis was present with restriction of all the extraocular movements. Maybe we can say as a frozen globe. On fundus examination, we could see a blurred disc margin with pale disc with a pale background retina and a brightish red spot in the macula, suggesting of right eye central retinal artery occlusion. Since he was a COVID positive patient and presented with a facial swelling and a eye complaint, that is inability to open the eye with severe proptosis, chemosis and frozen globe, the patient was taken for a multidisciplinary approach, ma'am. So after ophthalmic examination, the patient was shown to ENT specialist, where the ENT people have examined. Since he was a COVID positive patient, the diagnostic nasal endoscopy was done, but was done taking COVID-19 precautions, where they can see first on the examination they can see maxillary and ethmoid sinus tenderness, and there is some collection in the right side right side below the medial turbinate. The CT scan, which was the MRI scan, which was done 15 days before coming to KIMS, shows both the bilateral maxillary sinusitis with ethmoid sinusitis, and there was no orbital involvement 15 days back. So within a 15 days span of period, the patient developed orbital complaints. Coming to systemic examination, he was a conscious and oriented person with stable vitals, but his random blood glucose was 307 milligram per deciliter, which shows uncontrolled diabetic status of the patient. Since he was a COVID positive patient with uncontrolled sugar, the patient the patient was kept in isolation as he was a COVID positive patient, and there was a severe orbital involvement. So from our side, we have first proceeded with a conservative management, that is transcutaneous retroverbal amphotericin B, which was given to right eye from the next day of admission to the next alternative and second alternative days. The KOH report, which was taken on the day of admission by the ENT specialist, the report came negative. Okay. After that, since there is a more clinical suspicious of the orbital mucormycosis, the patient was taken for a diagnostic and endoscopic sinus surgery. After that, immediately the next day of the sinus surgery, the repeat MRI was done. In the MRI, we could see a hypofluorescence in the T1 weighted images in the right orbital cavity, and there is a hyperfluorescence with fast trending in both extracorneal and intracorneal space, and there is a bulkiness of the muscle. Orbital muscles can be seen. The histopathology report, where the biopsy was taken by ENT specialist, the histopathology report came as orbital mucormycosis, where the pathologist seen a broad non-septate hyphae in the specimen center. So after the 2 weeks of a presentation, the patient report came as COVID negative. The patient is COVID negative, and histopathologically proven mucormycosis was seen. So the patient was prepared for orbital excentration based on the SIN scoring system. On the clinic, it is based on 3 parameters, that is clinical presentation, fundus examination, and the orbital imaging. On the clinical presentation, the vision was PL negative, so score 3 was given. Pupil was fixed non-reactive. Orbital motility, it was almost a fixed frozen globe. So again, the score 3 was given. The patient presented with proptosis. So total 3 score was given. The total 12 score for the clinical presentation. On the fundus examination, where we can see a pale optic disc with central artery occlusion, so total 4 score was given for fundus examination. On the orbital, on the imaging of the brain orbit and paraneal sinuses, there is orbital involvement, so score 3 was given. There was an intracranial spread. Actually, there was an early evolving abscess of the temporal lobe was seen in the patient, so there was a minimal intracranial spread, so score 3 was given. Sphenical sinus was involved, so score 2. Frontal sinus involvement given score 1. But ethmoid, maxillary, and infratemporal fossa involvement, so total score was 4. So coming to the total score of the patient, it was 28. So it was exceeding the 25 of the total score. So the patient is prepared for the orbital excentration. So after, as we know, the orbital excentration is a disfiguring procedure. The detailed and the written informed consent was taken by both patient and patient attenders. It was a preoperative image of the patient where we can see a complete ptosis, proptosis, chemosis, and the frozen globe with PL negative vision in the right eye, being left eye within normal limit. So this was a right eye accentrated eyeball, which was sent for histopathological report. So this is a post-operative image where we can see accentrated cavity, where the cavity was filled with the amphotericin soaked gel. Amphotericin gel was soaked in a gauze piece, which was packed in the accentrated cavity to increase the local dosage, to increase the local penetration of the amphotericin B, where the intravenous amphotericin B will not reach.
Dr. Sumanga, please wind up.
Yes, ma'am. The total dose of liposomal amphotericin given was 6 milligram. This was a pictorial depiction where the patient presented with a complete drooping of the eyelid with ptosis and proptosis with frozen globe. It was a pre-operative image, and it is the post-operative image of the patient. Thank you, ma'am. Hello, ma'am.
Yeah, Dr. Sumangala.
Yes, ma'am.
You go to the slide with tram B details.
Yes, ma'am. Yes, ma'am.
The patient had left eye involvement also, or only right eye involvement?
Ma'am, actually left eye there is a complete involvement of the maxillary sinus node. Since the patient vision in the right eye was already PL negative, ma'am, and there is involvement of the maxillary sinus on the left side. So to as a prophylaxis and to prevent because there is a more chances of left side orbital involvement as there is a brain involvement and the maxillary sinus also involvement, and both sides sphenoid sinus was also involved. So as a prophylactic measures we are given to left eye.
But you have any literature for that?
Ma'am,
no, right? And MRI was done after you gave the tram B or before you gave the tram B?
Ma'am, we are given tram to right eye, ma'am. After right eye tram, MRI was taken.
After, not before.
No, ma'am. No, ma'am. After the tram to the right eye, we are taken.
So you gave tram B, then did MRI, then when did you do the exentation? After how many days of presentation?
Ma'am, after 2 weeks of presentation.
After 2 weeks of presentation?
Yes, because the patient was not willing, ma'am. So we have to convince the patient because the intracranial spread was also starting, ma'am. So to remove that necrotic tissue and to reduce the fungal load, we have convinced the patient after the patient and patient party agreed for the procedure, ma'am. So for that it took a long procedure, and patient was also COVID positive for 1 week. So for that the delay was happening.
What about what are the complications of giving tram B?
Ma'am, tram B, first there may be a there is a retroorbital hemorrhage, and tram B itself, if itself is itself will cause infection and the inflammatory reaction around the eye, ma'am. And during the procedure, there may be retroorbital hemorrhage may happen.
Oh, okay, thank you.
Yes.
Yeah, thank you, Dr. Sumangala.
Thank you.
Move on to the next speaker, Dr. Alka Kulkarni from KIMS again. Topic is subhyaloid hemorrhage, and mentor Dr. Rajshekhar Dyaberi. Dr. Alka? Dr. Alka, are you there?
Yes, ma'am. Hello, ma'am. Hello, ma'am.
Yeah.
I'll start sharing my screen, ma'am.
Please stick to time.
Can I start, ma'am?
Yes, please.
Good afternoon, everybody. I'll be heading with my case presentation. A 56-year-old male patient by name Baswaraj, who's a driver by occupation, heading from Dharwad. He came with the chief complaints of diminution of vision in left eye since 2 days. Coming to history of presenting illness, the patient was apparently all right 2 days back. Then he noticed diminution of vision in left eye, which was sudden in onset and it was painless in nature. 2 days back, patient gives history of
Dr.
sudden.
Alka, sorry to.
Your slides are not being seen.
Slides? Yeah, please share slides.
Yes, ma'am.
Are you able to share your slides?
Yes, ma'am.
Yeah. Okay, now we can see it.
Yes, ma'am.
Go ahead.
Good afternoon. I'll be heading with the case presentation. A 56-year-old male patient who's a driver by occupation and a resident from Dharwad. He came with the chief complaints of diminution of vision in left eye since 2 days. Patient was apparently all right 2 days back. Then he developed diminution of vision in left eye, which was sudden in onset and it was painless in nature. 2 days back, patient gives history of sudden shoot in blood pressure, which was nearly about 200 by 100 mm of mercury, for which the patient visited local hospital and he was treated for the same. There is no history of cough, vomiting, or any trauma to head. There is no history of watering, redness, burning, or no history of trauma. No history of pain, itching, or previous ocular surgeries. No history of diplopia, glare, or fever.
Past history, patient is a known case of hypertension since 5 to 6 months on treatment. There is no history of diabetes mellitus or tuberculosis or asthma. There is no history of similar complaints in the past. Coming to personal history, the patient has a good appetite with normal bowel and bladder habits with adequate sleep. There is no history of allergies or any addictions. No history of similar complaints in the family. Coming to general physical examination, patient is moderately built and nourished, oriented to time, place, and person. The blood pressure recording on the day he visited OPD was 150 by 90 mm of mercury, and the pulse rate was 80, and respiratory rate being 18 cycles per minute. Systemic examination was normal. Ocular examination, normal head posture, ocular alignment appears orthotropic. There was no facial asymmetry. On proper eye examination, on right eye examination, eyebrows were at the same level, eyelids normal, lid margins were normal, lashes were normal, palpebral height was about 11 mm and width about 28 mm, conjunctiva normal with optically clear cornea in both eyes. On anterior chamber, it was of normal depth, iris was normal color and pattern, pupil, it was 3 mm with both direct as well as consensual light reflex present. Lens was gray with nuclear sclerosis grade 1 in both eyes. Coming to visual acuity, the right eye vision was 6 by 9 parts with pinhole improvement to 6.6 and N10. In the left eye, the vision was counting finger 1 meter with no improvement. The best corrected visual acuity was plus 0.5 diopter spherical to 6 by 6 in the right eye, whereas in the left eye, there was no improvement with glasses. The tension in both the eyes was normal with Goldmann sublination tonometer of about 14 mm of mercury. The lacrimal apparatus appeared normal, and the color vision were normal, and the extraocular movements, ductions and versions were normal in both the eyes. On distant direct ophthalmoscopy, there was a uniform red glow noted in all the gazes in both eyes. On right eye fundus examination with optically clear media with the 90D slit line biomicroscopy, the optic disc was normal in size and shape with well-defined margins with a cup disc ratio of 0.3 with a healthy neuroretinal rim. In the macula, the foveal reflex was dull and the blood vessels were attenuated. Coming to the left eye fundus examination with optically clear media with slit lamp biomicroscopic examination, the optic disc was normal in size, shape, and color with well-defined margins, and the vessels over the disc appear normal with a cup disc ratio of 0.3 with a healthy neuroretinal rim. In the macular area, a bright bowl-shaped red pre-retinal hemorrhage of size 2 disc diameter was noted in the macular area. Vessels showed arteriolar attenuation. This is the diagrammatic representation of the fundus. Coming to right eye OCT picture, the foveal contour was well maintained with the vitreoretinal complex normal, the retinal layers were normal, and the retinochoroidal complex was also normal. This is the left eye OCT picture where the foveal contour was altered and there was a hyperreflectivity seen with posterior optical shadowing noted, suggestive of mainly the hemorrhage. So we came to the provisional diagnosis of right eye grade 1 hypertensive retinopathy changes noted, and the left eye subhyaloid hemorrhage secondary to accelerated hypertension with grade 1 hypertensive retinopathy changes noted. Left eye YAG hyaloidectomy was done under topical anesthesia. This was the immediate picture after treatment, which showed the color. In the first picture, we could see the trickling of the blood into the vitreous cavity. This is a picture wherein the blood flowed into the vitreous cavity. It was after treatment. This was the follow-up picture after 1 week of treatment, wherein the vision improved till 6 by 18. And in the fundus picture, we were noting almost complete resolution of the hemorrhage. And the OCT picture showing only the serous collection now. This was the follow-up picture of the case after 2 weeks, wherein the vision improved to 6 by 18, and there was near complete resolution of the hemorrhage near the macular area, and the foveal contour was almost well achieved on OCT. This is the pictures at the visit and immediately after YAG hyaloidectomy was done, and this is after the treatment. And this is the post-op follow-up picture when there was almost complete resolution of the hemorrhage. And this is the OCT, left eye OCT, wherein at the terminal visit, there was almost near complete resolution with the foveal contour well achieved on the left eye OCT. Thank you.
Thank you, Dr. Alka. That was a nice presentation.
Thank you, ma'am.
My question to you is, what are the other differential diagnoses that you will keep in mind? In your case, you said that it was the increase in the blood pressure which shot up. That's why, this patient developed. What are the other things that you would keep in mind, and what is the history that you would take, let's say, to rule out those?
Similar picture can also be obtained in Valsalva retinopathy, ma'am, wherein we need to ask about any repeated bouts of coughing or any vomiting was there, or was there a sudden strain or increased physical activities. It can also be Terson's syndrome, wherein we have to ask the patient regarding the history of trauma to head. So whenever there is subarachnoid hemorrhage, there can be sudden increase in the intracranial pressure, which can reflect back on the eye, leading to increased episcleral pressure, and it can lead to the hemorrhage. And I can also ask about the other blood dyscrasias which come later, and also if there was any diabetic history.
Correct,
Or if
yeah. And what and your description of the subhyaloid hemorrhage, the size of it, in your description you've written 2 disc diameters, and in your hand drawn picture you've written 1 disc diameter. To me it looks more like a 1 disc diameter. So in this situation, what are the other treatment options that you could have considered?
Ma'am, if it would not be efficient with the YAG hyalodotomy, we would prefer for the surgery like pars plana vitrectomy with pars plana vitrectomy could have been done with ILM peeling. Then we could have gone for the resorption of the blood under the ILM if it was. And we can also, in later cases, we can go for the injection of tissue plasminogen activator, also with cryopexy, pneumatic retinopexy can be done.
What are the risks of leaving this alone like this?
If this blood gets collected chronically for over a long period of time, then can be this blood substitutes itself may cause damage to the underlying photoreceptors, ma'am. So it may result in the permanent loss of the vision if it is left over a longer period of time.
And what are the things that you'll keep in mind when you're choosing your spot to give the laser?
Ma'am, when we'll look for the shape of the hemorrhage, wherein there is maximum convexity, we usually and the dependent part of the hemorrhage is usually chosen for the spot to be given, ma'am. And it should be always away from the fovea. It should be away from the fovea.
Definitely away from the fovea, away from not near any major blood vessel.
Major blood vessels.
And you should make sure that where you're giving the shot, there should be enough hemorrhage to prevent any damage to the retina, right?
Yeah.
And why was the vision 618 and the last follow-up? The OCT seems normal.
Yes, ma'am.
Any theory on why the vision didn't improve to 6.6?
Ma'am, refractive error might have been there, ma'am.
That was not checked, is it?
Actually, it didn't improve previously when we did, ma'am, with YAG hyalodotomy. It improved to 618, ma'am. Previously, it was not improving when the patient had visited for the first time. Later, after the OCT, after this YAG hyalodotomy, the patient did not improve much, ma'am, actually. Minimal serous fluid might have been there, ma'am.
But your OCT does not show that. While the OCT before the middle OCT which you had shown, that showed the other one.
Yes,
yeah.
Dr. Alka, was the FFA?
So how long?
Yes, ma'am.
I had a query, Dr. Alka.
Yeah, please.
Was the FFA done for this case?
No, ma'am. FFA was not done, ma'am.
No, because the fundus picture for me looks possibility of any aneurysm, I was thinking.
Yes, ma'am.
So that may be also one of the cause, no? Some grayish white spot is there, juxtafoveal, if you in the fundus picture.
Yes.
See here, you can see here.
Yes, ma'am. Actually, this was a flash, ma'am, during the fundus picture which was taken.
Not that one.
No,
the
not
imperial
one.
Yeah. I want an opinion from Dr. Rita if she wants to add on anything.
No, I was wondering how long after the appearance of hemorrhage was the YAG hyaloidotomy done?
Ma'am, he was taken on the same day, ma'am. He visited for the patient had visited on the same day, and he was considered for the YAG hyaloidotomy on the same day.
Excuse me. It was just 2 days. He presented to us within for 24 hours, madam. And when I saw him first time, I looked to me. I am Dr. Rashekar.
Yeah.
Hello.
We can hear you.
Madam, okay, it was considered quite within 24 hours, and we could notice immediately after my first, after doing hyalotomy, I could see the trickling of the blood, and immediately I showed it to postgraduates. And since he was a driver by profession, so I was very much concerned about him, about his vision. I selected a spot which is away from the fovea and blood acting like a cushion and convexity with a maximum stretch. There I noticed, and I just placed the spot of 2 millijoules, I believe, and it was done under Zeiss YAG hyalotomy. And the 618 correction, he had refractive error, that is uncorrected. Best corrected vision acuity would be better after this thing, glass correction, because OCT wise he was well settled. After I saw him last after 3 to 4 months after hyalotomy, he was doing fine. And as far as FFA is concerned, we could not do FFA as it was the observation is well taken. That was white spot which was there in that fundus. Probably one of the cause may be that. But I had a doubt. This superficial hemorrhage, what we see superior to the disc, that splinter hemorrhage, what we could see, this was noticed after say 6 weeks, after maybe 2 months after YAG hyalotomy. I was pretty surprised by this new sign which appeared. Vision wise, he had absolutely no complaint, but this superficial hemorrhage which appeared above the disc, I wanted experts.
Nice to see you, Dr. Rajshekhar. Hemlata here.
Oh, Hemlata, hi. Thank you. Thank you. Thank you. What might be the reason for superficial hemorrhage which we noticed above the disc? This was noticed, Hemlata, after 2 months after this YAG procedure.
No, I think maybe there is like uncontrolled hypertension or any blood diathesis to rule out in these cases, because looks more of superficial hemorrhage, no?
More of superficial.
Yeah, yeah. Feathery hemorrhage.
Yes, yes, madam. Yes, madam.
And
otherwise, he
yeah,
is doing
I
fine,
would like
madam.
to differ by the fact that I would have waited. I would have waited at least for 3 to 4 days to just see.
We
if the
can't hear
blood
you
settled
clearly.
or-
Your voice is breaking.
Yes, ma'am.
Is it better now?
Yeah.
Yes, ma'am.
Yeah, I was thinking we had a recent patient with diabetes and pre-retinal hemorrhage right in front of fovea. So this patient actually his vision improved spontaneously by just the setting of hemorrhage, since it was in the pre-retinal layer. So I would have waited little bit rather than going for this YAG laser right away on the day of presentation.
Yes, ma'am.
It was very next day, maybe second day, we have noticed this case. How many days should we wait, madam, for this? Because in my experience, I have seen these cases around, say, in 8 to 10. 2 to 3 cases have really done well after YAG hyalotomy. During my Minto PZ days only, I had seen few cases. So, of course, your observation is well taken, madam. How many days should we wait?
I would wait for at least 6 to 7 days.
Okay, 1 week. Okay. Probably this
Yeah, 1
patient
week.
was okay.
And
During
yeah, doing
follow-up?
FFA would give little more information. Yeah.
Yes,
As Dr.
madam. Yes,
Hemlata said.
yes, madam.
Thank you. I think we should move to the next case, but it was very heartwarming to see that the mentors have come forward. And thank you, Dr. Rajshekhar and Dr. Hemlata,
Thank
for
you. Thank you.
being a part
Thank
of
you,
the
madam.
discussion.
Thank
I think
you,
there's
madam.
one more case for the retinal judges next,
Yeah.
and then we have a last case of oculoplasty, and then we wrap up the session. Thank you so much, all of you, for being here and sticking on. Dr. Shilpa, over to you.
Yeah.
Thank you.
Dr. Rajshekhar, it was really nice to see you here and encouraging your students so much. Thank you so much. Now we go to
Thank
the
you, madam.
presenter, Dr. Harshita Nahata. The topic being nasal origin of cilio-retinal artery occlusion in CRAO. Mentor is Dr. Ramesh Venkatesh from Narayan Netralaya.
Good morning, good afternoon to all. Ma'am, is my screen visible?
Yes.
Am I audible clearly?
Yes, yes.
Okay. Should I try running it in slide share this mode, ma'am, or should I just continue like this?
Go ahead with this mode because sometimes it doesn't go forward.
Okay, fine. So, good afternoon to one and all. I am Dr. Harshita Nahata from Narayana Netralaya, and my mentor is Dr. Ramesh Venkatesh, and I'll be presenting a case of nasal origin of cilio-retinal artery and central retinal artery occlusion. So, a 56-year-old male patient who was a known case of uncontrolled hypertension since 15 years came to us with sudden painless diminution of vision in the right eye since one day. At presentation, his best corrected visual acuity in the right eye was 660 and in the left eye was 66. Anterior segment examination in the patient was normal and unremarkable. On dilated fundus examination of the right eye, we could see a diffuse opacification of the entire retina with involvement of the posterior pole and a very clear cherry red spot also. However, there was sparing of the papillomacular bundle temporal to the disc. Now, this is a slide wherein we have put a cropped and a zoomed image of the superonasal quadrant, wherein there is sparing of the retina up to the far periphery, along with a small area of a papillomacular bundle fold also. Yeah, and the left eye dilated fundus examination was absolutely normal and unremarkable. So our findings till now suggested that the patient had a acute central retinal artery occlusion in the right eye and the left eye was normal. We further went ahead and did a multicolor imaging to confirm our findings and the involvement of the area of the artery occlusion. Now, this is a OCT scan, which is, this is a vertical line OCT scan, which is running through the fovea. It shows the diffuse whitening and thickening of the retina, along with the increase in reflectivity of the inner retinal layers, along with shadowing effect on the outer structures. This is another OCT scan, horizontal line scan, which is running through the fovea and involving a little part of the optic disc also. Now, this scan shows a clear demarcation line between perfused and non-perfused retina. Now, coming to the question which we had in our mind was, why has this case of CRAO spared the nasal quadrant? We went ahead and did an angiography to confirm our findings. We did a combined fundus fluorescent angiography and indocyanine green angiography. In the early phases of the angiogram, we could see from in the right eye presence of 3 patent cilio-retinal arteries arising from the optic nerve head. There were 2 arteries which were arising on the nasal side of the disc and were perfusing the retina up to the far periphery, whereas there was 1 single temporal cilio-retinal artery which was perfusing the papillomacular bundle but was not involving the fovea. Thus, does the FFA and ICGA confirm sparing of the nasal branch of central retinal artery, the presence of nasal cilio-retinal artery, and was the fact that there was nasal involvement show less severe overall involvement of the retina in a case of retinal artery occlusion? This is a raster scan OCT, which is running through the disc and the fovea, which further represents wherein there is a very clear zone of demarcation between the perfused and the non-perfused retina, which we were able to see. Now, our case highlights a subtotal central retinal artery occlusion with multiple cilio-retinal arteries, which were rescuing the nasal retina. What we learned from our case was that in central retinal artery occlusion with a patent cilio-retinal artery, although not so common, but a nasal origin has also been seen. In cilio-retinal artery occlusion, sometimes they can be multiple arteries and they can also be originating nasally. Our case had a moderate visual acuity at presentation of 660. And at the last visit, there was a good visual outcome of 636 at the last visit. This we tried to explain by the fact that there was sparing of the papillomacular bundle. Also, the nasal retinal sparing was there, which involved a wide area, thus protecting the retina from ischemic damage. Thank you.
Thank you, Dr. Harshita. So, so this patient, the only comorbidity he had was hypertension, is it?
Yes, ma'am. Yeah.
Okay. And have you done a literature search on how common it is to have nasal cilioretinal artery being present?
Yes, ma'am, we did a literature research, but we were not able to find any study which had been done on the incidence of such cases. We could only find single cases somewhere where it was reported, but there's no prevalence as such that has been given for its nasal origin.
Okay, this was interesting to me also, but so I did do some reading up, and there was some Hungarian study in which they have, reported the presence of the nasal and the temporal cilioretinal artery, and some Chinese study also. And interestingly, some Indian author also has written, but that was a very old article, and he's not mentioned. He's just only talking about the incidence of the cilioretinal artery.
Yes, ma'am.
Now, if you didn't have all these investigative tools, how clinically will you identify a cilioretinal artery? What is the clinical identification?
Okay, this is when a patient of an artery occlusion is coming to us, right?
No.
Okay, in a normal patient.
So, let us say that, suppose at Narayan Netralia, you were going to do kind of a population-based study to find out how many people had cilioretinal arteries.
Yes.
And where was it present? Was it nasal, temporal, upper nasal, whatever, to describe the location? How will you identify the cilioretinal artery?
Ma'am, we would like to focus upon the arteries arising, we would like to focus on the vessels arising from the disc. So normally we only see the major retinal vessels which arise from the disc. But in case there is another vessel which is arising from the disc and it is not branching out into or meeting the main vessels at any point, that gives us an indication that it is a independent vessel which is arising from the disc. And just as here we see that it can be in any area, it can be temporal, it can be nasal. So we should not be biased about the fact that we are only looking at the temporal side to look for a cilioretinal artery.
Yeah, but then the classical picture is of a hook shaped, like a walking stick. Yeah, so that's how you identify it.
Yeah.
So in your, if you look again at your pictures, you have actually 2-3 points where you can see the cilioretinal artery, the existence of it. I think not this picture, no, maybe the
fundus picture.
Like fundus picture, yeah.
Here. Is it visible, ma'am?
Yeah, it is.
Yeah.
And the vision, you said it has improved, but it has improved by a line which is kind of marginal. So
yes,
I didn't quite. So there is a part of the, like you said, this papillomacular bundle area which is perfused. So I mean, and you said that the presence of the nasal presence of the cilioretinal artery, it helps in reducing the incidence, the later complications of ischemia and all that, but that would be further down the line, right? And
yes, ma'am.
How do we?
But the fact that we are trying to say here is that however much portion of the retina is spared, it could be in any area, it could be nasal, it could be temporal or inferior, but the area of the retina which is spared, that is eventually the one which is responsible for how much vision we are able to get back. So we also saw another case of a nasal cilioretinal artery in our OPD, but then that was in that patient the papillomacular bundle was not spared, that was involved, and a very less area of the retina was perfused by that artery. So in that patient we were not able to achieve a good outcome, even though the patient presented really early. So what we are trying to say is that the visual outcome, it depends on two things. First is whether the papillary macular bundle is involved or not. Secondly, how much of the area of the retina overall is involved or is spared. So now, because we had this nasal cilioretinal artery, which was actually perfusing quite a bit of the retina. So that is what actually was the reason that the vision in our patient was better.
Okay.
So,
okay. Thank you so much. I think we move on to our last speaker now. From Kasturba Medical College, Manipal, Dr. Joy Bhatt. The topic being more than what meets the eye, a rare presentation of a sebaceous carcinoma. Mentor, Dr.
My slides visible?
Yes.
So today my talk is titled More Than What Meets the Eye. Because when I first saw this patient, it looked like a case of a chalazion, which was rather large in size. But on further probing, it turned out to be something that I had never seen before as a resident. So a 34-year-old male presented with complaints of swelling of the upper lid since the past 3 years, which was insidious in onset, painless, and progressing in size over the past 3 years. The patient described it as a round lump, which was rather smaller in size than the current presentation. And it was not associated with pain, redness, decrease in vision, no increase in decrease or complete resolution of the swelling. There was no discharge or bleeding from the swelling, no proptosis, diplopia, no fever, weight loss. The patient had presented to an ophthalmologist in 2020, and they were suspecting a malignancy, so they did a biopsy, which was suggestive of an infiltrative basosquamous carcinoma. And the patient was then referred to a hospital, and he showed up a year and a half later due to the prevailing pandemic at the time. So the patient has no comorbidities and is a quadri worker by occupation, has normal bowel and bladder habits, and has no similar complaints in the family. The best corrected visual acuity is 6.6 and 6 in both the eyes. In the left eye, we can see a small with the rule astigmatic component, which I can associate to the findings that I'm going to present forward. The extraocular movements were normal in both the eyes. The anterior and posterior segment examination of the right eye were within normal limits. The left eye, the eyelid showed a firm non-tender nodular lesion over the upper eyelid at the medial 2/3 and lateral 1/3 junction, measuring approximately a centimeter by a centimeter involving the lid margin. And there was also a loss of cilia at the involved margin. And there were telangiectatic vessels which were seen over the lesion. On eversion, a pedunculated, fleshy, cauliflower-like lesion was seen measuring 8 millimeters by 6.5 millimeters, extending from the tarsal conjunctiva. There were also, which also had fine telangiectatic blood vessels over it, and there was no preauricular, submandibular, submental lymphadenopathy. The rest of the anterior and posterior segment examination was normal. At this point, a preliminary diagnosis of left eye, upper eyelid sebaceous gland carcinoma was made, and the patient was planned for an excision biopsy with upper lid reconstruction by a Cutler-Beer technique. Intraoperative frozen section was done for margin clearance, and 6 weeks later, the Cutler-Beer, the bridge flap was released. These are intraoperative pictures showing the lower lid bridge flap used to close the upper eyelid defect, and picture B shows a scleral allograft that was used to reconstruct the tarsus. These are the histopathology pictures of the patient, which confirmed a sebaceous gland carcinoma, which was poorly differentiated. In the center picture, you can see the tumor forming different lobules and nests with a cystic pattern. And this is the final outcome of the patient 2 months after the surgery. The patient was satisfied with the aesthetic outcome and has been advised to follow up biannually for the next 3 years as per the current follow-up guidelines. So, 30% of sebaceous gland carcinomas have a tendency to recur, since most of them have a multicentric origin and also the potential to metastasize. So, which makes it necessary to carry out at least a complete excision biopsy with intraoperative margin clearance and lymph node biopsies when indicated. So, lymph node biopsies are to be carried out when the tumors are staged as a T2C according to the AJCC or higher. In this case, it was staged as a T2B, and also there was no palpable lymphadenopathy. So thus we did not conduct, we deferred the lymph node biopsy. There are also some recommendations. Some recommend to do a conjunctival map biopsy in tumors suspicious of multicentric origin. However, that was deferred as an excision biopsy with intraoperative margin clearance was done. Also, there is insufficient evidence about the supremacy of map biopsies over excision biopsies alone. So sebaceous gland carcinomas are also associated with an autosomal dominant disorder by the name of Muir-Torre syndrome. And patients with these with sebaceous gland carcinomas are to be screened for the same. So in his case, the Muir-Torre syndrome risk score was 1, and thus we did not investigate for the same. And lastly, this patient was rather a young patient to present with a sebaceous gland carcinoma, since these carcinomas present in the 5th to 7th decade commonly, which makes this case somewhat an oddity. And that concludes my presentation. Thank you so much for listening.
So, like you started with your presentation, you said at the end, what would be your differential? I mean, yeah, we concluded the sebaceous gland with the histopathology, but what else would you think it would be when you looked at the patient?
That first looks, if we're considering a malignant lesion, then it would be a nodular variant of either squamous cell carcinoma or basal cell carcinoma.
Yeah.
But in this case, a sebaceous gland carcinoma was considered because one, it involved the upper lid, and the upper lid has numerous meibomian glands, so therefore it has a bigger predisposition for sebaceous gland carcinomas.
What about HIV testing? Was it done?
HIV, the patient's serology was negative. I'm sorry, I forgot to mention that. But the patient was negative for serology, was not undergoing any immunosuppression, had not undergone any radiotherapy for any kind of acne or other systemic conditions.
Okay. The conjunctiva was involved only the prolapse part of the conjunctiva was where there was
only the tarsal conjunctiva was involved in the upper lid. The bulbar conjunctiva was not involved. I mean, on grossly, but histopathologically we did not. Yeah, grossly. Histopathologically we did not do that since we didn't do map biopsy.
Okay, but during the frozen section, the margins of the conjunctiva were free from the tumor involvement. Yeah. Okay.
Yes. Yeah.
Okay. But anything else also you want to see? Like, okay, 34 years is really very rare, right? So just for discussion at large, the other conditions that can also present like this other than malignancy?
Other than malignancy in terms of a tumor of the lid, or I mean, are we talking about systemically something to look for?
No, systemically, we already said HIV, and the other thing would be
Lynch syndrome and Muir-Torre syndrome.
Yeah, but like simple cysts, right? We start with very simple.
It could only, just on looking at it, it could be a granuloma, like a chalazion which has undergone granuloma formation.
Yeah,
that's what I thought when I first saw it.
That would still be first, but because she also has a previous history of tumor excision and biopsy where they have shown that it was some other carcinoma. Yeah, so that would be again why would you would suspect, that's why you would suspect malignancy again here in this case. But otherwise, if you were seeing her for the first time, it would still be like a chalazion or a cyst like any of the other gland cysts in the lid. So that would be first. But loss of cilia is another thing which features the carcinoma as such. Right? Yeah. Okay then, thank you.
Yes, thank you so much, Dr. Joy. I think we are done with all the presentations. It has been a little late, but it is very encouraging to see everyone still sitting here. The presentations were very good, very interesting. And I thank all the judges for having made their time today for this wonderful, wonderful session. And Dr. Samina, a special thanks to you. You're always there where boss is there. So it's really been a great session today. And after a long time, we are back to a little bit of online, little bit of offline. So it's been a good experience. And thank you so much for involving me also in it. It has been a great learning looking at all these presentations. And thank you all once again.
Thank you, Dr. Shilpa. Thank you so much. You've been such a pillar of support for this particular program and in general otherwise also. There are a lot of people who are behind the scenes when such a program has to be conducted successfully. I would like to, on record, thank Dr. Shravya Devasani, Mrs. Leena, the entire Elargan team over here. Thank you so much. And once again, a heartfelt thank to all the judges for all your painstaking effort to stick on the entire Sunday morning, spilling over in the evening you've given to us. And I cannot thank you all enough. Thank you so much to the speakers. And let's do such more programs together. Let's together learn more things. And I'm very thankful to the mentors also. I saw a few of them who joined and pitched in. So thank you, thank you, thank you. And thank you to the WAS Central for giving Karnataka this opportunity. Hoping to see all of you soon. The participants must be very eager to know who are the first three winners of this competition. Please be patient for another one more day. You will get your result on mail tomorrow, and everybody who is participated will definitely get a proper participation certificate. All the speakers and the judges will also get the certificate for being a part of this program. And thank you once again. Have a great evening. Make the most of this Sunday evening. Thank you so much. Dr.
Thank
Shilpa,
you, ma'am.
Thank you.
Thank you so much.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
Bye-bye.